Me.
Sujitra, start. Sujitra.
Shall we start the meeting?
Yeah, sure. Sure.
Okay. Good morning, everybody. We, the Ophthalmic Society of Kannur, warmly welcome you all to this Scientific Committee CME Series 2022, Module 2 on this Sunday morning. Taming the Beast, as it is rightly called, we have wonderful speakers from all over India who will unfold the common corneal problems. So let us begin this meeting by a prayer song by Dr. Vanathi, who is currently the Nightingale of OSK.
Siva, it's not playing in our this thing. Sima, can you hear me?
Let me just check, sir.
You have to just open the video and then share it.
Unshare this now.
Unshare this link.
Now open the video on your computer and then share. Yeah.
You can start from the beginning.
From the beginning.
Yeah. Sima, one more problem actually. You have to share your sound also. While screen sharing, you have to share the sound. You have to click the option, share the sound. Unshare and unshare and start sharing again once more. So when you are sharing the screen, there will be option just below that. Share my sound.
സന്തതം കരതാരിയെന്നൊരു ചിത്രചാതുരി കാട്ടിയും സന്തതം കരതാരിയെന്നൊരു ചിത്രചാതുരി കാട്ടിയും അന്തചാരു കടാക്ഷമാലകൾ അർക്കരശ്മിയിൽ നീട്ടിയും അന്തചാരു കടാക്ഷമാലകൾ അർക്കരശ്മിയിൽ നീട്ടിയും ചിന്തയാ മണിമന്ദിരത്തിൽ വിളങ്ങുമീശനെ വാഴ്ത്തുവിൻ വിളങ്ങുമീശനെ വാഴ്ത്തുവിൻ വിളങ്ങുമീശനെ വാഴ്ത്തുവിൻ.
Now I request Dr. Simi Manoj, our Dynamic President OSK, to deliver the welcome address.
Hi. Am I audible? Am I audible?
Yes.
Yes,
Okay. Okay. Very good morning to all. Thank you all for joining with us today. Ophthalmic Society of Kannur is extremely privileged and honored to conduct the second module of the CME series arranged by the KSOS Scientific Committee. We have selected a very interesting topic to all, that is cornea, the practice pulse in keratitis management and common corneal procedures. Now, let me get on to my job. Firstly, I'd like to welcome our Honorable President of KSOS, Dr. Ajit Chakravarti, who needs no introduction. He's an internationally famous figure. Sir, I welcome you to this program and for the inaugural function. Next, I would like to welcome our dynamic officials, two dynamic officials, General Secretary of KSOS, Dr. Gopalas Pillai, and our energetic Scientific Committee Chairman, Dr. Srini Adakalan. Both of them have helped and guided us a lot in bringing out the CME. Welcome you both. I would like to welcome our member Scientific Committee Chairman, Dr. Sujit Nayana, who is a tech expert, and he has also helped us a lot in coming out of the technical issues. Now, I would like to welcome our all chairpersons, Dr. Vinay, Dr. Anil, and Dr. Anita Jabbar. I bid a very warm welcome to the keynote speakers of today's program. They are excellent teachers, and I'm sure this is going to be a fruitful session for all of us today. I welcome Dr. Prasanth Garg, Executive Chair, LVPI, Dr. Vanathi M., Professor of Ophthalmology, RP Center, AIMS, Dr. Somsheila Moorthy, Head of the Department of Cornea and Anterior Segment, LVPI, and Dr. JK Reddy, Director of the Shankara Eye Care Institutes. We welcome you, sir, to the CME. Now, I would like to welcome my team members, my energetic secretary, Dr. Seema, Scientific Committee Chairman, Dr. Leda Mohan, and our Treasurer, Dr. Liji, all other members of the Ophthalmic Society of Kannur, all KSOS members, and all other delegates who are joined with us today to enjoy and attend the CME. I'm sure I assure you that this is going to be a worthy and a productive CME, precious, and it will be very great for you to attend the CME. Thank you all one day now.
Thank you, ma'am. Our Honorable President of KSOS, Dr. Arup Chakravarti, has kindly consented to inaugurate this scientific module. So, with your permission, shall we virtually inaugurate this CME?
Absolutely. We have to, the lamp lighting is I think that is scheduled now?
Yes, sir. Yes, sir. Yeah. Shall we share that video, sir, no?
Yes, yes, please.
Good morning, Arup, sir.
Good morning.
Anita, sir. Hi, Asha, madam. Hi, Seema.
Hi, madam.
Hi, Sujit.
Hi, hi. Now I request Dr. Arup Chakravarti, Honorable President KSOS, who has taken KSOS to great levels, both at national and international levels, to deliver the inaugural address.
A very good morning to you all from President KSOS. I would start off by congratulating our dynamic scientific committee chairman, Dr. Srini, for envisaging a very ambitious plan of conducting CMEs, webinars, starting from Kasargod to Talasedi to Trivandrum. And I would also like to take this opportunity to congratulate Kannur Ophthalmic Society to rise up to the occasion and prepare a fantastic scientific program. I need not really elaborate on the program because when I went through the list of the talks, the gamut of the talks, it covers all aspects of corneal infection, and it also includes some interesting talks by one of the pioneering innovators in Indian ophthalmology, Dr. JK Reddy. So it is, and of course there are Ksos stalwarts. We have known them extremely well, and I'm sure they're going to have a very good scientific program. One important aspect of the program, as I saw in a post made by Dr. Srini, is this program is dominated by female members of Kannur Ophthalmic Society, that's the office bearers. And in fact, in a research that I did before I became president of KSOS was the last couple of years, the female members of KSOS have been presenting more than 90% of the papers, posters, videos. They have been running away with the awards. However, on the leadership role, there are not many of them present. I think the same thing is reflected here. So next meeting that you organize, I hope it will be 100% all-woman team. And that is something that I will definitely look forward to. As regards the speakers, a few comments on them. Dr. Prasanth, he may not be aware that when I was very young, I had gone to LV Prasad as to participate in this ICLEP program, that contact lens program. I happened to go to the theater, saw his surgery. I realized he was a great surgeon in the making. And then he has grown in ranks and now he heads LV Prasad. And I have something common with him in the fact that his son is doing his MBBS in the same place where I studied. I hope Prashant, he is doing extremely well and is happy about his, you are happy about his progress, growth and development there. Dr. Vanathi, of course, I've also known her and we have traveled the AIOS journey together for quite some time. She is extremely knowledgeable, a good surgeon. I have known her when she was working at Arvind in Pondicherry before she went to RP Center as a faculty member. She is extremely erudite, she's a good surgeon, and she is an asset to any meeting that she participates in. Dr. Somsheila Moorthy, yes, before I knew who she was, I knew that she was a very enthusiastic person. I used to see her in the international airports corridors, bounding the staircase up and down, very enthusiastically, making her talks. And by the time I got to know her, she has already grown in stature. And now she is one of the leading lights in cornea, in cataract surgery, as well as an uveitic, the Indian Society of Uveitis. So I think we have had a great, we have been lucky to have a great team, and thank you KOS for this, for getting them here. JK Reddy, of course, was sort of my contemporary at Arvind. He was in cornea. He was different in every way, right from the olden days that I have known him. And no CME in Kerala is complete without JK's participation. He has extensive knowledge about what is happening in KSOS. In fact, if I want to know about a common friend whom I have not heard about, I ask JK, how is he? I have not heard about him. And invariably he comes up with his ideas about, Arup, these are the new hospitals that are coming up, these are the new things that are happening. So we can't conceive a project, any academic program in KSOS without JK Reddy. So again, thank you, Kannur Ophthalmic Society, for getting one of these very versatile, ophthalmologists for this meeting. I would not take much time by talking about cornea because you have all experts and giants in the field, participating in this program and spreading light on the various topics. But a few aspects of KSOS, particularly from the visiting faculty and for the rest of the KSOS members, is webinars, of course, are going on, and we have started online journal clubs. and 2 editions are over. And we also plan to have KSOS on demand. So all the programs on Drishti 2021 will be on the website, and Srini and his very efficient scientific committee will take over. And we will send mails and messages up to us about those various scientific contents that happened. We really have a wealth of information and wealth of topics that have been covered there. Our focus also has been, thanks to our secretary, Dr. Gopal, and Chairman Scientific Committee, Dr. Srini, on public education, eye literacy. So we have laid great emphasis on informing the public about non-communicable diseases. We have had 2 webinars on substance abuse, and we had one on World Disability Day. Then about when the Omicron, the variant came to the country, we had a public awareness program. We also have a lot of programs upcoming on non-communicable diseases for public awareness and vision enhancement clinics, and many more such programs. And for the youngsters, we have formed cells which will support the NABH accreditation support. There will be instrument purchase assistance committee, infection control cell, and many such programs are on the anvil. And we have just about 2.5 months down the line in this particular year. And by the time we finish, I think we'll have a lot of things that have been covered with the help of the office bearers, very dynamic office bearers and KSOS. So with these words, I wish this particular CME all the best, have a great learning experience, and go back feeling extremely wise and learned at the end of the session. Thank you so much.
Thank you, sir. No scientific session is complete without our dynamic Dr. Gopal sir, Secretary KSOS. Now I request Dr. Gopal sir to kindly felicitate this CME.
Thank you very much. I hope I am audible. Yeah. So thank you very much, Dr. Arup sir, for pushing all of us, particularly me and Srini, into these programs. And I think the brain behind this program being Srini, I think all the hard work has been done by the Ophthalmic Society of Kannur. And congratulations, Dr. Simi, Dr. Seema, Dr. Lata, and all the other office bearers of the OSK for having this conceived this program with stalwarts like Prasanth sir, Somsheila madam, Vanathi madam, and JK Reddy. And of course, Sujit is the invisible force behind this, who has shaped this program, I know. And congratulations to you, Sujit. This is the second of the series from, of each district of Kerala conducting a separate CME under the aegis of KSOS. That's a wonderful program, right from Kasargod to Trivandrum. Srini has placed each district in the academic map of Kerala Society of Ophthalmic Surgeons. And with this, we cover almost all parts of ophthalmology under the aegis of KSOS, each district spearheading that. This has been pushed basically also because of the COVID waves and the physical meetings not having happened. There were a lot of initial hiccups of bringing in the virtual programs. And I congratulate the Kannur Society for bringing this up and let this program go on really well. All the best to this program. All the best to all of you. Thank you.
Thank you, sir. Now I request our own Dr. Srini sir, Chairman Scientific Committee KSOS, to felicitate this. His hard work and dedication is seen in all the scientific sessions.
Thank you. Good morning, everyone. Respected President Dr. Arup Chakravarti, Secretary Dr. Gopal Pillai, everyone, good morning. See, as Arup sir said, this is the second program in our KSOS Scientific Committee CME series. And as Gopal said, we'll have one program in each district. It should have ideally started from Kasargod, but we started it with Kozhikode because it's Sujit's place. Sujit is our scientific committee member, and under his guidance, we had a really wonderful program organized by the Recurrent Ophthalmic Society, and we had more than 1,600 views for that program, which is quite huge these days, because the same day the AOs had done a same program on cataract, and the views were 600, 700. So we had almost double the views. That means that we are doing a wonderful program. The biggest advantage here is that each district ophthalmic club is taking the lead to conduct a CME program for KSOs. It's not just you put the name of under the aegis of KSOs. No. So they are doing it, and as a scientific committee member, Dr. Sujit. So the first 4 districts, Sujit will be guiding, then the next 4 districts, Prof will be guiding, and next 4 districts, Thomas will be guiding. And this guidance direct from the KSOs is definitely helping the district ophthalmic clubs. The Ophthalmic Society of Kannur is conducting a major scientific program after District 2019. I mean, I understand, after 3 years. So this has been initiated by KSOs, and now Ophthalmic Society Kannur will carry on. So that's the basic idea behind the KSOS Scientific Committee CMA series. And next month it's going to be for the glaucoma week. It is going to be at Kasaragod, and Kasaragod Ophthalmic Society has never done a major scientific program. They're going to do the scientific program for the glaucoma week for KSOS, and it will be a major program. So see, our greatest strength for me and Gopal, our greatest strength is Dr. Arup Chakravarti. See, we are really lucky to have him as our president, because when I tell everywhere that he is the most famous Indian ophthalmologist, and he has contacts everywhere. He knows what is happening everywhere, in and out, and he has been guiding us, and he has been pushing us. He's been scolding us, everything, but it's pushing us to put in our best for the KSOS. And just a word about Dr. JK Reddy. JK sir was my teacher, and Arup sir said, you ask him anything about ophthalmology, he'll tell. You ask him about anything, sir. You ask him about cars, you ask him about ladies' lipsticks, he'll have an idea about everything. So he's such a genius, and his session is definitely going to be great. Dr. Prasanth, see, I've gone through his articles, his talks, and everything. But it's the world of it's a treasure of information there. Whenever he talks, whenever he conducts a program, and Vanathi was my senior at AIMS, and she's very dynamic, she's very strong, she's very knowledgeable, and she'll definitely do justice to the topic that is given to her. And Dr. Somsheila Moorthy is one of the best in a specialty. So all the best, and I'm sure this is going to touch a view of 2000. Thank you.
Thank you, sir. Now we'll wind up the inauguration session by vote of thanks by Dr. Seema, who is the backbone of this CME.
Before that, I just want to interject and say that, I mean, this was one program which was ready very much well in advance. Unlike many programs where we see last minute activity, almost 2 to 3 weeks ahead, the whole program was ready. Everybody, I think Dr. Simi made umpteen number of phone calls to ensure that things go on well. So this is one, Srini, this is one unique the nature of this meeting. And please ensure that the subsequent CMEs that take place, they use this as the role model, the yardstick, and conduct the CMEs. Thank you so much.
Thank you, sir. Good morning, all. Respected President, all senior faculty here, and dear friends. As a representative of Ophthalmic Society of Kannur, first of all, let me thank KSOS for giving us the series. Let me extend my heartfelt gratitude to Dr. Arup Chakrabarti, Honorable President KSOS, who kindly consented to inaugurate our CME. My sincere thanks and respect to guest faculty, Dr. Prasanth Garg, Dr. Vanathi, Dr. Somsheila, and Dr. JK Reddy, who in spite of their busy schedule, readily consented to deliver the keynote address in each of the sessions. It was very kind of you. Next, I would like to thank senior KSOS faculty who agreed to chair the 4 sessions, Dr. Anita, Dr. Vinay, Dr. Anil, and Dr. Sujit. It is only because of their guidance and help that we could frame the CME into this shape. With equal importance, I would also like to thank the panelists in all the sessions for their wholehearted cooperation, and also PG doctors who are presenting cases in 2 sessions. I would also like to acknowledge Dr. Srini and Dr. Sujit for their valuable advice and moral support with which we were able to take this forward. My special thanks to Dr. Simi, President OSK, who was supporting and helping me throughout in the process of framing the entire CME. Let me also thank our scientific committee chairman, Dr. Lada, and treasurer, Dr. Liji, for helping me in the entire process. Last but not the least, let me thank Dr. Sharmil, who readily agreed for all backstage support today, and also Dr. Sujitra, who is compiling for the function. I would also like to acknowledge Mr. Subhash, Mr. Sudesh, and Simi Madam's son Anirudh, who helped us with the flyers and brochures. And finally, let me thank everyone taking the time to join us today. Thank you all once again.
Okay, thank you, Seema. Now we'll move on to the scientific session. The first session will be on microbial keratitis, which will be headed by Dr. Anita Jabbar, who is a senior consultant in Eye Vision Hospital, Chalakudi. Apart from all her academic achievements, which we see in the slide, Madam is a graceful dancer. We, the lady ophthalmologists, are a great fan of her, all her skills. Over to you, Madam. Questions can be posted in the chat box, YouTube chat box. Madam.
Seema, shall I share my screen for the introduction?
Yes, Madam.
So can you stop sharing this?
Yeah.
Is my screen visible, Seema? Am I audible?
You are audible, but your screen is not visible.
Screen share has not started, madam.
Okay, give me 2 minutes.
Seema, if you can hear me, you can mail that file to Mr. Ankit. He can do the screen sharing.
Sujit, I think now it is visible. The screen is visible.
Yes, now it is visible. Yes.
Yeah. Good morning. A warm welcome to the first session of microbial keratitis other than viral. And I thank the organizers for this wonderful opportunity. And I thank Dr. Seema for the introduction.
Madam, can you make it full screen?
Yeah,
presentation?
Sure. So it is my proud privilege to welcome our esteemed faculty, guest faculty, Dr. Prasanth Garg. I'll be introducing all the faculty back to back, and I welcome our panelists, Dr. Asha Madam, Dr. Libby, Dr. David, and our PG who presents the case presentation, who does the case presentation, Dr. Danya. Dr. Prasanth Garg is the Executive Chair of L.V. Prasad Eye Institute, and he is the successful successor of the founder chair, Dr. G.N. Rao. Dr. Prasanth is an internationally renowned leader in corneal infections, antimicrobial resistance, and eye banking, and is an authority in each of these topics, and it is a very blessed surgeon as well. He is the recipient of numerous prestigious awards, both national and international, and he is on the boards of several international organizations, societies, and scientific journals. He obtained his medical degree and specialization in ophthalmology from the Ravindranath Tagore Medical College, Udaipur. His association with LVPI dates back to 1996 when he joined as a fellow. And in all these years, he has held several leadership positions in the organizations. This include Director, CAR Campus, the Center of Excellence in Hyderabad, Director, Kodi Venkatadri Chowdhury Campus in Vijayawada, Network Head of Eye Banking, Network Head of Education also. He also holds the Paul Debord Chair of Cornea. He has over 190 scientific publications in peer-reviewed journals and has authored several book chapters. He has been an invited faculty for the prestigious international meetings and has delivered several named lectures. He is blessed with 2 boys. He spends his spare time with his loving family and friends and enjoys traveling and touring to new destinations. His inspiration is helping patients from blinding eye diseases, and seeing the smiling faces satisfies him most. And I happily invite you, sir, to deliver your keynote address.
Thanks, Anita.
I'll finish the introduction of the others also, sir.
Okay.
Our panelist includes Dr. Asha Chandrasekhar Madam from GMC Kannur. She did her graduation and post-graduation from Calicut Medical College and fellowship in cornea and microsurgery from Aravind Eye Hospital, Madurai. She has a keen interest in teaching and she is a postgraduate teacher for the past 8 years. I welcome you, Madam, for the panel discussion. Dr. Libby Joseph is the additional professor of ophthalmology in Government Medical College, Kottayam. She did her undergraduation and post-graduation from Government Medical College, Indore. Though a trained phaco surgeon, she has a special soft corner of infections for the infections of the cornea and management. And I welcome Dr. Libby for this session. Dr. David Pudukadan is the Chief of Cornea Services at Little Flower Hospital, Angamali. He was my colleague when I worked there. He is the Assistant Medical Director at Eye Bank Association of Kerala, which is at Little Flower Hospital. And he did his fellowship in cornea and external diseases from Aravind Eye Hospital, Coimbatore. I welcome David for this session. And thank you all for joining. And I thank the organizers for this wonderful opportunity.
Thank you, Anita, for the generous introduction. And I'd like to begin my talk first by thanking Kerala Ophthalmic Society for inviting me. I also would like to thank Dr. Arup Chakravarti for generous introduction. Yes, my son enjoyed his stay in Jipmar and really has grown well during his tenure. Currently, he's doing his MD in radiation oncology from the same center. Dr. Gopal, thank you for inviting me to this scientific session. So I'll be today talking to you my journey into corneal infection and what has kept me focused on this topic. I do not have any financial disclosures to make other than the grants that I receive from ICMR, Department of Biotechnology and Medical Council of UK. The objectives of my talk will be to share with you some of the interesting cases of corneal infection that really made me continuously engaged with this topic. I will also talk to you about antimicrobial resistance in ophthalmology and whatever research we are currently doing as far as this topic is concerned. I'll begin with this case of 25-year male who presented to us with a history of 6 weeks duration of pain, redness, watering, and diminution of vision following a metallic foreign body removed by local ophthalmologists. This was the case that I saw when I was about to finish my fellowship. By then time, Dr. Madhukar Reddy, who was mentoring me for corneal infection, and Dr. Savitri Sharma gave me enough confidence that at the first glance, I said, oh, this is microbial keratitis and should not be difficult to manage. In those days, we were treating these cases with ciprofloxacin, and therefore we started this patient on ciprofloxacin after finding that there were no organisms seen on microscopy, and the culture showed a growth which was identified as Corynebacterium. The patient showed initially some response, and we were happy. But 4 weeks later, this patient presented with a new lesion in the central cornea with increase in symptomatology. Without doing anything, we switched over to cefazolin and gentamicin. The patient again started showing response, and then at 8 weeks later, while the peripheral lesion resolved, the central lesion persisted. Now, this case brought me down to as far as my confidence was concerned. I thought, what we are doing such that this patient is over past 2 months has not resolved, despite being given a broad spectrum antibiotic coverage. We thought, let us review back the history. And we found that this was the patient who already had a treatment for 6 weeks duration. That is, this is a slowly progressive disease, and the size of the lesion was much smaller compared to that. The disease started following the removal of metallic foreign body. And then this patient had a waxing and waning course. And once we put those 3 points together, we immediately realized that we are, or probably might be, dealing with an atypical mycobacterial infection. We repeated the corneal scraping, and this time we took acid-fast staining, or additional slide for acid-fast staining. And we found there were faintly stained gram-positive bacilli, and then they were strongly acid-fast. We could immediately relate all of this to that we probably missed this organism and labeled this smear as negative because of the staining character of this microorganism. This time, fortunately, we got a confluent growth on blood agar, which was then identified as Mycobacterium chelonim. We published that case soon after I joined as a faculty. Subsequently, around 2015, one of the residents was given this thesis to work on all the non or atypical mycobacterial keratitis. And we analyzed the data of 52 cases that were managed between 95 to April 2014. And we found that this entity definitely is a diagnostic challenge, particularly because there is relatively less awareness about this microorganism. The clinical signs are not very typical, although the textbook says cracked windshield appearance, but our data did not identify that. And number 3, that most of the time using conventional microbiology, these organisms stain very faintly and therefore are often labeled as negative on microscopic examination. But there are certain other characteristic features which will help us in identifying this organism. Number 1, close to half of the cases present with a relatively long duration of symptoms ranging between 1 to 3 months. Number 2, the trauma is the most important predisposing factor, particularly following surgery. And therefore, if you have a history of metallic foreign body or prior surgery, then that becomes another indicator for this. This organism or this infection has been seen following a variety of surgical procedure. You name, and then you will find in literature that there has been an infection caused by this. It came into light much more when there were a spate of infection following LASIK by this organism. So if you have a patient who presents to you with a long history of being treated with antibiotic corticosteroid, and continue to show waxing and waning course, you must keep a diagnosis of atypical mycobacteria in mind. Even if you have not taken the additional acid-fast stain, you can decolorize the gram stain and then examine it under microscope following staining with acid-fast or Ziehl-Neelsen technique. The management, we did the minimum inhibitory concentration and found azithromycin and clarithromycin to be the best drug. But this organism also responds very well to amikacin, which is available both as commercial formulation, and you can really enhance it by making it fortified using injection. However, you need to be aware of that the treatment duration is usually long, and amikacin may lead to some toxicity in the form of pseudomembranous conjunctivitis. Another factor that you need to keep in mind that in some of these patients, the infiltrate may remain localized in the deeper area, and therefore you may have to resort to surgical modalities such as keratectomy, lamellar keratoplasty, or even a full thickness penetrating keratoplasty. Let me take you to another acid-fast organism, which is nocardia, and it is another fascinating organism that we published in my earlier career. The fascination came from the typical morphology that you see on the cornea, a beautiful wreath-like presentation of calcareous pinhead-sized lesions. And if you pass a blade on these lesions, you will get a gritty feeling on scraping. So this was an organism that we studied extensively. We wrote a first survey article way back in 2000 on this organism. And we found that the diagnosis of this acid-fast organism is relatively simple, particularly if the patient presents with a typical feature. And then on the gram stain as well as on the acid-fast stain, you find these long filaments which are beaded. But these filaments are much thinner than fungal filaments. So you should not confuse these with the fungal or with the fungi. This organism, that is nocardia, is very unique. It causes a variety of infection, right from keratitis, scleritis, endophthalmitis, canaliculitis, and orbital cellulitis. So practically, it can infect any organism. But as I said earlier, it has a very characteristic clinical feature, a very characteristic morphology on microscopic examination, and even on the culture media, it produces a typical chalky white growth, and that is very easily identifiable. However, another feature is that this also presents with a slowly progressive disease with a long duration of symptoms. One should not get confused that all the patients present with typical feature. There are many patients who have a clinical picture that mimics fungi. And therefore, a microscopic examination and the culture are very essential in the diagnosis of this organism. Fortunately, this organism also responds very well to aminoglycosides. And the paper that we published in Clinical Microbiology, Infectious Diseases, we found that amikacin is a very good drug followed by gentamicin, and therefore these two drugs can help you take care of this organism. On an average, the mean duration of resolution is around 30 to 40 days. Let us now move on to some other infections that have fascinated me. These were the cases that we saw around 2008 or so, when we saw multiple patients presenting to us with follicular conjunctivitis, with some papillary reaction on the tarsal conjunctiva. These patients had punctate erosions on cornea. Some of these patients had bilateral conjunctivitis. At this point of time, we were unaware of what kind of organisms can cause. And as typically we were not doing any scraping, we thought this is adenovirus. Once we got the understanding of microsporidia, we started doing corneal scraping from these elevated chalky white lesions, and we found abundant of these microsporidia both under KOH chalcofluor white as well as acid fast staining. And that began our journey into microsporidia. We published extensively on this topic and still continue to get fascinated by this organism. The organism is typically described as being intracellular eukaryotic organism and is thought to be an opportunistic pathogen, typically causing systemic infections in immunocompromised individuals. So that's the classical description. And earlier cases of microsporidial keratoconjunctivitis were also thought to be in patients having human immunodeficiency virus infection. Today, we know that microsporidia can cause ocular infection, and these are primarily keratoconjunctivitis and stromal keratitis. The keratoconjunctivitis presents with a typical raised chalky white lesion. Some of these may be very large in an eye which has follicular or papillary congestion. In this aspect, this disease differs from Thygesson's punctate keratopathy. Thygesson's punctate keratopathy produces similar lesions on cornea, but the eye is absolutely quiet. Number two, Thygesson's punctate keratopathy lead to a kind of a recurrence of symptoms, whereas microsporidial keratoconjunctivitis is non-recurrent in nature. So coarse punctate keratopathy with conjunctival injection is the hallmark of keratoconjunctivitis caused by this organism. Some of the patients may present underlying stromal reaction, almost mimicking nummular keratitis and even the pigments on endothelium. As I said that the earlier reports were all into the immunocompromised individuals, but when we published our report, which occurred simultaneously with the similar report from Singapore, that we realized that this disease can happen even in immunocompetent patients. So this organism gave us thought. We published multiple papers on microsporidial keratoconjunctivitis, describing its epidemiology, treatment, and outcomes. So we realized that during rainy season, when there is contamination of the water, probably there is higher risk of people acquiring this infection. This was proven both in Andhra Pradesh, Telangana region, as well as in Odisha. There was a debate around the treatment of this infection. People thought that they require some kind of bigonides and other things. But in a randomized clinical control trial by our group from Bhubaneswar campus, led by Dr. Sujata Das, we proved that this disease resolves spontaneously in 1 to 2 weeks, and you need to provide only symptomatic treatment to these cases. The next was the stromal keratitis. We looked at and we found that the duration of symptom is even much, much longer. Some of the patients present with the history of more than 1 year duration. The typical presentation is like that of HSV stromal keratitis. Even at our center, despite having knowledge of microsporidia, many of these cases were treated as HSV stromal keratitis before they were diagnosed as microsporidia. It can lead to a purulent keratitis as seen with any other organism, and can also lead to a corneal melt and perforation as shown in these two slides. Previously, we were making diagnosis through corneal biopsy examination or histopathology of excised corneal buttons. But once we got knowledge, we are doing corneal scraping, and these microscopy is helping us to establish the diagnosis of stromal keratitis. Although there are a variety of drugs described for the treatment of this disease, but in our view, the only definitive management of this disease is keratoplasty, and that too penetrating keratoplasty. The two cases where we attempted DALK both developed recurrence of infection and had to then undergo penetrating keratoplasty. More recently, we have got another organism that is currently become a focus of our interest. This organism presents as a typical fungal keratitis. However, these fungi are different, and this became obvious to us when we were dealing with this patient who, despite being diagnosed as fungal keratitis, continued to progress to involve entire cornea, and then corneal button was excised and subjected to histopathology examination and microscopy, where we picked up that there is atypical features in these patients. They are relatively rapidly progressive. They develop intraocular extension, and they do not respond to antifungal treatment. We then looked at the morphology of this organism. A typical fungal filament has a septate, and they are more of cylindrical nature, whereas the filaments of Pythium are flat and ribbon-shaped. These cases were then investigated using molecular diagnostic techniques as well as zoospore formation, and we could characterize the microbiology of this organism. Actually, if you see this area, there is a faint growth on the culture plate, which then was subjected to zoospore formation, and that resulted in identification of this organism. So currently we do both the molecular diagnostic technique as well as the zoospore formation in order to diagnose these cases. Another characteristic feature is fine tentacle-like lesions that extend into surrounding cornea, or you may find these dot-like lesions. And then the lesion develops slowly guttering at one of the edges. So all these features help us in making the clinical diagnosis. In these cases, earlier we thought that no drug is effective, and surgical treatment had poor outcome because of the recurrence of infection. However, one of the resident fellow did a project where they found on the literature search that Pythium is in systemic infection managed with linezolid. This same antibiotic is also used in plant pathology, where the plants get infested by Pythium. And therefore, we started treating these patients using linezolid. In the first paper that we published 17 patients which were managed with linezolid, and we found that 12 resolved to medical management. From no response to medical management to such a high rate of resolution gave us a lot of confidence in managing these cases. Let me take you to the antibiotic resistance. My first journey into the antibiotic resistance was in 1999 when we, for the first time, published presence of fluoroquinolone resistance among Pseudomonas isolates of keratitis. And we showed that there is a progressive increase in this level of resistance. That gave a lot of enthusiasm to other workers on looking at the ciprofloxacin, ofloxacin susceptibility, and many published the resistance to first generation fluoroquinolones. It brought to 8 methoxyfluoroquinolones, and we then in 2010 published that although the typical belief was that these drugs are unlikely to develop resistance, we showed that close to half of the isolates were resistant to Getty, and nearly 93% of the isolates of Cipro-resistant Staph aureus were resistant to Moxi. The same was true with the Cipro-resistant Streptococcus pneumoniae. We also published our data on methicillin resistance and found that even in India, methicillin resistance among Staph aureus and other gram-positive organisms is following the same trend as elsewhere in the world. Since we were monitoring susceptibility of isolates, we looked at the Pseudomonas between 2006 and 2012, and we could discover sudden increase in the resistance level in 2011 and 12, and which was attributed to contamination of a preservative-free topical eye ointment, which was later on withdrawn, and currently the level of resistance has returned back to around 40%. We also participated in an Asia Cornea Society infectious keratitis study, which is a multi-centric, multinational study to understand epidemiology and drug resistance. And we could, using pooled data, could demonstrate that countries like India, Philippines, and China have relatively higher level of resistance or insensitivity compared to the countries like Singapore, Thailand, Japan. The other important aspect of this resistance was that in India, many of these isolates were resistant to 4 or more classes of antibiotic. If you look at the green bar here, this is resistance to 3 antibiotic and the resistance to 3 or more antibiotic accounting for close to about 55% of the resistant isolates. This gave me a lot of interest into antimicrobial resistance, and I came across with a group from University of Sheffield who was working on hyperbranched polynipam polymers. It's a very interesting polymer that if you tag this polymer with antibiotic moieties, this functionalized or this polymer becomes functionalized. When it comes in contact with the microorganism, it collapses, exposing all its binding sites on the surface to which more organisms can bind. They were trying to develop a skin dressing using this polymer. We thought if this polymer has such a strong binding, which is specific, that is the vancomycin tagged polymer will bind only the gram-positive organism. It will not bind the gram-negative organism, whereas the polymyxin tagged polymer binds only gram-negative organism and it does not bind gram-positive organism. We wrote a grant to Wellcome Trust to develop this as a diagnostic contact lens, and we developed a fungal binding polymer as a part of this grant. This has amphotericin B monomers tagged onto the polymer, and it shows a specific binding to the Candida albicans as well as Aspergillus and Fusarium. And we showed that by tagging the polymer on a hydrogel and demonstrated that vancomycin polymer was able to bind lot of gram-positive organism, polymyxin lot of gram-negative, and amphotericin B to Candida albicans. We then loaded it over to a hydrogel, which is transparent and can be textured as a contact lens. We applied this contact lens-like device onto the rabbit-infected eyes and looked at that how much organism bind in the presence of inflammatory cells, and we found that quite a substantial number of these organisms could bind once the device is placed onto the eye for half an hour. This promoted us to write another grant to look at, can we overcome resistance by increasing the concentration of drug at the site of infection? And in that attempt, we realized that the drug like basifloxacin and levofloxacin have relatively poor penetration through cornea. We then created a formulation using polyvinyl alcohol and polyvinyl pyrrolidone and found that this 5% gel had a much better penetration into the cornea, both for basifloxacin and levofloxacin. This formulation has been now patented, and we soon will reach or approach industry to start manufacturing commercial formulation using this. We then started looking at alternative ways of drug delivery. We developed a microneedle patch that can be applied on cornea. You can see this hydrogel transparent patch. It goes onto the cornea, and these patches are loaded with the drug. The moment you leave this patch onto the cornea, all the drug is released into the stroma. These are the microstructure of these needles. And if you apply onto the cornea, it penetrates to close to about 200 microns into the cornea. These needles disappear very quickly. Within 60 seconds, you will find that all the needles are dissolved and whole drug is released into the corneal stroma, such that you achieve very high concentration of drugs into the corneal tissue. And this device we have tested with basifloxacin, we have tested it with pilocarpine, and we have tested it with amphotericin B. Now we are going to be working on really characterizing it so that it can be used for treatment of fungal keratitis. We also developed a transparent contact lens that can be applied on the cornea following cataract surgery. We loaded it with moxifloxacin and dexamethasone and looked at the diffusion kinetics into the corneal tissue. So we worked on a variety of drug delivery systems. All of this brought a lot of contacts with other polymer chemists who were working in the field of biofilm prevention. And when I read their work, I immediately recalled that we have a contact lens related infectious keratitis, where we see a lot of biofilm that is responsible for contact lens related infection. So we came across with the scientists in industrial area where they were trying to develop a nanocomposite formulation containing silver to coat the walls. We discussed with our requirement, and then they developed this nano silver as an antibacterial substance. This has a very unique texture. I think if you remember the lotus leaves, they do not allow any water to stay back. And if you make any surface extremely hydrophobic, no organism can adhere to. And if you add silver to it, then it gives a lot of antibacterial property. We came across this paper in Nature Biotechnology, which developed a coating to coat the catheter, and we started working on this onto the contact lens cases. This was the coated lens surface. This was an uncoated lens surface. It was very easy to apply the coating of the nano silver formulation onto the contact lens cases. This is the biofilm in 24 hours on uncoated contact lenses, both using gram-negative and gram-positive organisms on transmission electron microscopy. And this is the picture on coated lenses on 24 hours after application of biofilm load of microorganism. These are gram-positive, these are gram-negative organism, and you can see that even under very high magnification, there are no gram-positive organism and very few gram-negative organisms. So we have now published this work in the Investigative Ophthalmology Journal, and we are now extending this to include other substances for coating of sutures and other instruments. With this, I like to conclude that the study of corneal infections has been very fascinating for me, because while working on this, I have not only helped patients who suffer with painful eye condition, but it has helped me to grow as an academician, not only in terms of opportunities for publication and presentation, but meeting some wonderful scientists who really were looking forward to work with the clinicians. So it gave me a flavor of clinician scientist, and got the opportunity to have a funding for my research work. I like to thank my postgraduate students who worked on these projects. Without their help, I don't think so we could have done anything. And the support of team in LV Prasad Eye Institute, as well as all the funding agencies. Thank you once again for giving me opportunity to share with you all the work that I have done. I don't know whether I have taken much longer than what was required. Thank you very much.
Thank you, Dr. PG, for that enlightening talk. That was a great talk and a great eye-opener. And I'm very happy to get an opportunity to know the nice research work going on in LVP for the medical management of microbial keratitis. And I really appreciate your efforts to take part in this session. And I feel very fortunate to have learned many, many things, both clinically as well as surgically from you, sir.
Thank you, Anita.
We will be discussing some of the points in the panel discussion, sir. And without wasting much time, we will go to the second part of our session, that is a case presentation by Dr. Dhanya Dhananjayan. And we know microbial keratitis is always challenging, as you are showing in all the 4-5 different cases. So like a similar case, we would like to present before this panel. Dr. Dhanya, can you share the screen, please?
Yes, ma'am.
Yes, Dr. Dhanya, it is visible now.
It was visible, ma'am. Okay.
Yeah, it is visible and you're audible. Please carry.
Yes, ma'am.
Please put slideshow.
Slideshow. Okay. It is visible now in slideshow, ma'am.
Yeah, very much.
Yeah. A very good morning to all. Today we present to you a 30-year-old gentleman, painter by occupation, who presented to us with pain, discharge, and watering in the right eye of 4 days duration. He was apparently normal 4 days back when he gives a history of, it started with pain in the right eye, which was insidious in onset, gradually progressive, and was associated with redness, watering, foreign body sensation, right-sided headache, and photophobia. It was associated with purulent discharge in the right eye, which is also of 4 days duration. He doesn't give any history of any colored halos. He denies any history of ocular trauma or foreign body fall. There's no history of exposure to contaminated water, contact lens use, or self-medication. No similar complaints in the other eye. He had visited local hospital 1 day after the symptoms had started, and there is no history of any foreign body removal. Patient was already on eye drops, moxifloxacin and natamycin 4 times per day and hometropin 3 times per day when he presented to us. There is no history of any systemic illnesses, no non-drug allergy, no similar episodes in the past, and there is no history of any ocular surgeries, lasers, or intraocular injections. And also, there is no history of any topical medication before this illness. There is no similar complaints in the family, and his personal history is not significant except that sleep was disturbed due to the pain.
General examination and systemic examination was within normal limits. Moving on to ocular examination, head posture was normal, no facial asymmetry, eyes were orthotropic, no proptosis or nystagmus. Extraocular movements, ductions, versions, and vergence were normal in all directions. Orbit was normal in shape, with orbital margins normal. Moving on to vision, in the right eye, best corrected visual acuity was 636, which was not improving. Near vision and color vision could not be assessed. In the left eye, it was 612, improving to 66 with +1 sphere, 0.5 cylinder at 135 degree. Near vision and color vision was normal. Moving on to slit lamp examination in the right eye, lid edema was present, lid margins and lashes were normal, no blepharitis, entropion, ectropion, trichiasis. Yes, ma'am.
Dr. Danya, sorry to interrupt you. Due to lack of time, just go to the salient points. No negative history and all, no need.
Okay, ma'am. There was intense conjunctival and circumcorneal congestion with purulent discharge in the right eye. Right eye cornea was normal in size and shape with loss of luster and transparency. There was a 2 into 2 mm epithelial defect in the paracentral cornea with underlying grayish-white infiltrate with feathery margins involving anterior and mid-stroma. Stromal edema was present in the immediate surrounding with relative clearing of the periphery. No satellite lesions were seen. Corneal sensations were normal. No corneal vascularization was seen. There was a 0.5 mm hypopyon, which was mobile and flat. Anterior chamber showed as cells of 4+ with hypopyon, no keratic precipitates, mid-dilated pupil, lens clear, intraocular pressure was digitally normal. Posterior segment media was hazy due to corneal pathology, and disc and vessels were just seen. Left eye anterior segment and posterior segment was within normal limits. So in summary, we have a 30-year-old painter, no systemic comorbidities with complaints of pain, redness, and discharge in the right eye 4 days duration, with best corrected visual acuity in the right eye of 636 and the left eye 66, and right eye showing 2 into 2 mm central epithelial defect, grayish white infiltrate, feathery margins extending to the midstroma, lens was clear and posterior segment normal, and left eye within normal limits. So from the clinical examination and history, we came to a diagnosis of a fungal keratitis in the right eye. And syringing was done in both eyes, which were free. Corneal scraping was done. KOH and gram stain, no organism was detected. Culture also showed no growth. Routine blood test and LFT RBS were within normal limits. So we had empirically started the patient on moxifloxacin, natamycin, fluconazole 1 hourly, along with cycloplegics and analgesics. However, the ulcer was worsening, and on day 5, the infiltrate was increasing in size. Few satellite lesions started adding up. Surrounding cornea was more edematous with steamy pulmonal infiltrates. So we did a repeat scraping, which also came negative. So we added voriconazole 1 hourly. There was a slow waxing and waning course of the ulcer, but ulcer gradually worsened, and by day 22, we had the ulcer was 4 into 4 millimeter infiltrate, and the satellite lesion started coalescing with the main lesion, extending to the deep stroma. Corneal edema and the DM folds also increased. So suspecting a secondary infection, we did a repeat scraping. Grams and the KOH came negative. But along with that, we had also given an AFB stain wherein we got many acid-fast bacilli. The blood agar, chocolate agar, and SDA was negative, and we couldn't do a culture on acid-fast bacilli. So as a part of the treatment, we stopped all the antifungals, added fortified amikacin drops 1 hourly, started TAP clarithromycin 500 mg twice daily. There was, however, no response to treatment, and ulcer was progressing. Patient was in severe pain. So by day 30, we did a therapeutic keratoplasty, and post-operatively, we started on eye drops, amikacin, moxifloxacin, hometropin, along with anti-glaucoma medications and tear substitutes. Oral antibiotics was continued, and steroids were started at 3 weeks. 1 month post-op, the graft is clear, showed peripheral scarring at graft host junction, sutures were intact, lens was clear, and fundus was normal. So we came to a diagnosis of atypical mycobacterial keratitis.
Dr. Danya, can we stop with this?
Yes, ma'am.
So we have a case before us. This was an indolent. This ran an indolent course, which was clinically treated as fungal keratitis. It showed no response, and repeated scraping showed mycobacterium, atypical mycobacteria, and medical treatment was given. Still, when there was no response, a therapeutic PK was done. We will discuss this in the panel discussion. So thank you very much, Dr. Tanya, for your excellent presentation.
Thank
you. Can you stop sharing the screen?
Yes, ma'am.
Now I invite all the panelists, Dr. Asha, Dr. Libby, Dr. David, and Dr. PG. Kindly put on your videos and join the panel discussions.
Dr. Danya, what was the concentration of amic acid which was being used? You can just mention the concentration.
So 5% amic acid drops was given. Okay. And we had used the amic acid injection, which was available in 100 milligram per 2 ml concentration.
Okay. Can I speak now?
Sure, ma'am.
Some things are very unusual in this case. One is the history. This is an apparently healthy male who doesn't give a history of trauma. So that is one thing we should take into account. And another is that this patient, he has been started on antifungals without a scraping which has been positive for fungi. I would like to ask Sir Garg, sir, for his comment on this, starting antifungals initially without a positive KOH report.
Yeah, so actually, Anita or those of participants who have been my fellow, they will realize that I am a very strong believer of that antifungal drugs should not be started unless you have a microbiology workup. Empirical antifungal treatment has two disadvantages. Number one, since the fungi take long time to respond, you remain in a disguise that you have started some treatment and it delays the diagnosis. Number two, the antifungal drugs are mostly suspensions and they themselves can lead to toxicity. So our classical teaching is that the treatment, empirical treatment in a patient where microbiology either has not been done or has been negative should be started treatment with a broad spectrum antibiotic. Evaluate the response for up to 72 hours. And if the patient is not responding, definitely do the repeat microbiology or send it to a center where microbiology facility is available.
I think we should give Dr. David a chance. Why was fungal clinically suspected and why didn't you suspect atypical at the beginning? Because I know it is a very tricky question.
Madam, the patient had presented to us following treatment from another. Already the patient treatment was started and the ulcer was approximately 2 into 2 millimeter in size. So when we did a scraping, it came as negative. The problem is that when you have a 2 into 2 millimeter ulcer, there is high likelihood that the material which we obtain for scraping is very less and it might not turn positive. And the ulcer was clinically looking fungal. So it was already started on an antifungal, which was when it had presented to us. So that was one reason why we added a second antifungal to give a chance or give a try. But to be frank, we were wrong in our diagnosis. Actually, when patient came to us, when we did a third culture, that time only we had a intuition that it could be something other than a fungal infection. There was some amount of inflammation. The ulcer was not responding to the treatment, even after giving maximum amount of antifungal. That was the time when we thought about an atypical organism which could have affected. And retrospectively thinking, the patient was a painter by profession. Painters are exposed to toxic chemicals, which includes paint, turpentine, which is present in the atmosphere. That might have predisposed for a secondary infection like fungal or atypical bacteria. So It is actually most of the time there is a high likelihood of missing a diagnosis of atypical mycobacteria, and it is usually diagnosed at a later stage because it mimics other organisms like fungal and all when it presents at an early stage. So that was why it was missed at an earlier stage and later diagnosed.
So if you are not getting a scraping, positive scraping results, what is the next step? If there is an epithelial defect, you can do a deep scraping. And if there is no epithelial defect and the infiltrate is deep, in the deep stroma, does corneal biopsy has a role in this?
And definitely, if in a small ulcer, maybe a 2 into 2 millimeter, doing a repeated scraping might not yield an positive result. So another option which is left behind is to do a corneal biopsy. But in considering this case, usually in a corneal biopsy, they'll be doing a Grams KOH, blood agar, chocolate agar, and SDA agar. So if you need to have a suspicion for a typical organism to diagnose all these infections. So when you are sending a corneal biopsy also, you should specifically ask them to do a AFP staining. Otherwise, there is high likelihood that this sort of infection will be missed.
And what is your take on this, Dr. PG? When you suspect, routinely, will you ask them to do special stainings or special media in all the cases?
Not necessary. I think if a patient has a long history or is not responding to your conventional treatment, then it's a time that you should keep in mind the diagnosis of a typical organism. If the scraping is negative, at times you can discontinue antibiotic for 24, 48 hours, give them lubricants and cycloplegics and reevaluate them. You most likely will be able to arrive at diagnosis. So we usually do that. And this case was unusual in a sense that there was no history, predisposing factor that could be elicited. But I think unless we ask that very carefully, some of these patients forget their history because the duration between the inciting event and the onset of symptom is usually prolonged. So the patient is not able to relate. If 3 weeks earlier I had a foreign body, I will not relate to that. So I think part of the reason why you get a negative history is a long duration between the event that predisposed for infection and the onset of symptoms. So that has to be also kept in mind. I am not questioning why antifungal, why this. I think this is a typical way in which these cases are diagnosed. But the message or the lesson that we can learn is if a patient is not responding to your primary clinical diagnosis and treatment after adequate length of time and your microbiology is negative, you must look carefully. Are you missing these unstained bacilli? If you keep that in mind, you will be able to pick up many of these cases.
And Dr. PG, in your presentation, you were telling azithromycin was supposed to be to give better results than amikacin. Are you still in NTMs? Are you still giving azithromycin?
So we give azithromycin as an oral tablet, and we give amikacin because amikacin is also equally effective and it is a cidal drug. So you are giving a cidal drug which penetrates very well. You can increase the concentration to 5%. So you are having advantage of fortification and commercially available drug as well. We are not able to hear, Anita. You are.
Sorry. So in the chat box, there was a question. If there is no good microbiology workup and if there is, the ulcer is worsening, how to go about this? Scraping negative, culture negative, not responding to fortified antibiotics, no good microbiology workup. How do we proceed?
So such cases should be referred to centers where good microbiology is available, because what you are anticipating is that this patient is now going to go downhill. before it reaches a no return stage, if you can refer that patient, either medical management or a surgery at a stage where the outcomes are likely to be good, will be beneficial. No point in holding them to you with the inadequate arms in hand.
Can we give empirical antifungals?
No.
I believe empirical and antifungals, anti-amoeba drugs and all, which are all tissue toxic, should be never given empirically.
Yeah.
And that is the message Dr. PG is also stressing upon. So we will ask one or two quick questions to other panelists. Asha madam, I know you are dealing with many bacterial ulcers. So bacterial ulcers, we can, in the therapy of bacterial ulcers, you can either give a broad spectrum, fourth generation fluoroquinolones as a monotherapy, or a combination of fortified eye drops with a commercially available. So how do you practice? And in those cases, when you give fortified drops, what will you advise the patients?
So routinely, like if it is a very mild ulcer, means less than 2 millimeters, not involving the center of the cornea, and with not much of a stromal, deep stromal invasion, probably I would start with a fluoroquinolone, that is the moxifloxacin, which can be started hourly. But if the ulcer is center involving more than 2 to 3 millimeters and has got a deep stromal involvement, then I would preferably go, after getting the gram stain report, ruling out fungus, I would start the patient on fortified antibiotics. That is one situation. A second situation is like, suppose it's already culture proved that it has got sensitivity to drugs only like vancomycin or amikacin, which are not available as commercial preparations, then probably I would go for a fortified antibiotic. So these are so initially, if it is a non-peripheral ulcer, non-center involving mild ulcer less than 2 millimeters, probably I would go for a broad spectrum fluoroquinolone. Sir, any comment on that?
Fortified eye drops, how will you tell the patients how to?
Okay, so one thing is that the first thing that the person who is giving the fortified antibiotics, that is the doctor, he should label it, and it should be labeled and the date should be written properly on that. And for drugs like amikacin and vancomycin, usually it should be refrigerated at 4 degrees centigrade, and they are thought to be more stable for about 1 week. So you can label the drug. And another thing is to tell the patient to shake the bottle well before putting it. And I usually tell the patient to bring the drugs whenever they come back to you, to monitor their compliance also, to see whether they are using it properly. These are the usual things that I tell the patients.
Exactly, madam. These are very useful tips. And when you are treating an ulcer, suppose the ulcer was resolving, but at some point the ulcer you feel that it is worsening. So 2 things you should keep in mind: either the diagnosis is not correct, or the complaints of the patient, and also sometimes the toxicity can happen. So when will you suspect toxicity?
Yes, we have encountered many situations of toxic conjunctivitis when treating bacterial keratitis, especially with fortified antibiotics like amikacin and vancomycin. So I usually suspect a toxic reaction when I see that the corneal infiltrate is actually improving, but there is an increase in lid edema and increase in the congestion, and you find pseudomembranes on the inferior tarsal conjunctiva or sometimes small conjunctival ulcers. That is the time when and the patient is already on a drug like amikacin or vancomycin, that is the time when I suspect a toxic reaction. Actually, the infiltrate, I concentrate more on the infiltrate, the corneal infiltrate. If I see that it is coming down, then I know that I am met with a case of a toxic conjunctivitis. And then I try to reduce the dose a little bit and then monitor the patient closely.
Yeah, if there is non-healing epithelial defect and if there is surrounding like signs of toxicity like that next cell symptoms, you should suspect toxicity. And Dr. PG, I would like to like about your advice regarding starting steroids in bacterial keratitis if you are sure of the microbiology proves that it is bacterial, and referring back to the SCUT trial.
So I think the SCUT trial very clearly demonstrated that in terms of visual acuity at 3 months and 3 weeks, there was no difference between the group that was treated with corticosteroid or without steroids. The study also found that there were no adverse reactions. So I think the jury as regards use of corticosteroid in bacterial keratitis is still not out. The only paper that probably supports institution of corticosteroid is their 1-year follow-up, where they found one line of difference, that too in patient presenting with severe keratitis and of pseudomonas nature. I rather like to be more cautious in using corticosteroid, particularly because we are or ophthalmologists in our country treat cases of microbial keratitis empirically, largely. Number two, we have such a high prevalence of fungal keratitis or organisms in bacteria that are otherwise known to become worse on steroids, such as nocardia, atypical mycobacteria, burkholderia. These organisms really become worse on corticosteroid. So if you put the SCUT trial in the perspective of the scenario in India, you probably can safely say, if I do not get a high benefit from use of corticosteroid, why should I bother about it? And specifically if you go wrong, the risks are very high. So if you put that perspective, I think my understanding and my beliefs are steroids have no role in the management of bacterial keratitis.
Dr. Anita, I think time for the session is
5 minutes more. I shall take.
Yeah,
so 5 minutes.
Before ending, can I ask one query to Dr. Prasanth?
Sure.
Sir, what do you feel? See how because intracameral moxifloxacin, as we are on the topic of resistance. See, intracameral moxifloxacin has been used for a long time, and I from my presentations at DSCR and all, I've seen that there is a high incidence of resistance to moxifloxacin, but use of intracameral is effective because the use is at a much higher concentration than the systemic MIC. I agree with that, but with the rampant use of moxifloxacin, how long do you feel that moxifloxacin is going to stay effective as an antibacterial agent? And just a query.
So the 8-methoxyfluoroquinolones, they came with a lot of promise because of their dual mechanism of action. However, we have very clearly demonstrated that over a period of time, their efficacy for gram-positive infection is declining. So for the treatment of bacterial keratitis, I'll say that moxifloxacin is already losing its value. However, for intracameral uses as a prophylaxis against infection, it may still continue to hold value for a relatively longer period of time because you are injecting much more drug for a relatively smaller load of microorganisms that get entry at the time of infection. The other advantage you will get is that even if the infection happens in those cases, the severity of the infection or endophthalmitis will be less. So to answer your question, what will be the value or how long this drug will be able to sustain? For keratitis, we have already left it only for mild cases. We do not advise it for the severe cases. For prophylaxis, it may continue till a new drug or molecule comes, which has equal penetration into the aqueous humor and is similarly non-toxic. So you can still enjoy using moxifloxacin for intracameral injection.
Perioperative as topical antibiotics?
Yes, that purpose is different. See, nowadays people are questioning, is there a true value of prophylactic post-operative antibiotic? Once you give intracameral and your wound heals in 48 hours, is there a need to give antibiotic to these patients? Many of us are questioning, why are we giving it for 5 days, 7 days? Some are using for 2 weeks. No, the people are worried about legal cases and all of that, but there is no science. Following intravitreal injection, people were giving antibiotic, and now the study has shown that after 4th injection, you are colonizing conjunctiva with drug-resistant organisms. So we probably are doing more harm in using antibiotic post-operatively rather than giving benefit to.
Thank you.
Thank you, sir. One last question to Dr. Libby. I know you are dealing with fungal keratitis more. So what are the challenges you face, and what percentage of your fungal ulcers are being medically managed?
The main challenge that we have is diagnostic only, to find the etiology of the ulcer. And since it is a government setup, we do not have access to all those latest technologies. And we still stick to the age-old procedure of wet KOH mount and examining it under the microscope. And in many of the cases, we do not get fungal elements. And since we do not have any other method to confirm our suspicion, we trust our clinical sense and start antifungals and then wait for it to respond. And if it is responding, then we realize that it is probably fungal. And most of the cases that we deal, they heal by medical treatment only. The therapeutic keratoplasty is in very few cases, especially nowadays when we don't get donor corneas because of this corona. So most of them heal medically itself.
Due to lack of time, I think many questions are remaining. So I thank Dr. Prasanth Garg for his wonderful talk and for his time. In spite of his busy schedule, he agreed to come with us and spend his precious time with us. I really thank you, sir. And I thank all my panelists as well as the audience for being here. Thank you, sir.
Thank you very much.
Thank you, Prasanth. Thank you.
Thank you, Dr. Prasanth Garg, sir, for such an informative talk. Thank you, Dr. Anita ma'am, for chairing the session wonderfully. And thank you, Dr. Asha, Dr. David, and Dr. Libby for giving your valuable suggestions. And questions in the chat box can be answered by the guest speaker or the chairperson in the chat box itself. Okay. So now, without wasting
most
much
are answered, I think. I think most of them
most of them are answered actually. Thank you, ma'am. Now, without wasting much time, we'll move on to the next session on viral keratitis. I request Dr. Vinay S. Pillai, Senior Consultant and Head Cornea and Refractive Services, Giridhar Institute, Kochi, to chair this session. His special interests are on ocular surface disorders, keratoprosthesis, and pediatric and eclectic corneal disorders, and also on corneal transplants. Over to you, sir.
Thanks again for asking me to be here. Seema, I have to share the slides, right? Am I audible?
Yes, sir. Yes, sir.
Please share the slides and introduce the keynote speaker and panelists, sir.
Right. Hope this is visible.
Full screen.
Thanks to it is full screen, sir. Has it come?
No, not yet.
Now, how is it now?
It is just starting. Yeah, now it's okay.
Thank you. So once again, thanks to Dr. Seema and Ksos for asking me to do the session. I'll directly go to my job of introducing the faculty because of the lack of time. We have none other than Professor Vanathi from All India Institute, who is going to give a keynote lecture on the update in viral keratitis. It's difficult to read out all about her, but all of us know Professor Vanathi, and an excellent teacher with myriad of how shall I put it, interest both in academics and otherwise. Welcome, madam. We hope to have a great lecture from you. Then we have other panelists here. Dr. Lailan Bhatt, who's at present cataract and cornea consultant in UAE. She was in Little Flower, Angamali for quite some time before she moved to UAE. Welcome, madam, to this session. Then we have Sachin Matthew George, who is at present working in Chennai Hospital and consultant in a few other hospitals. Sachin has done a post-graduation and fellowship in cornea from Aravind Eye Hospital, Coimbatore. Welcome, Sachin, to this session. Then we have Dr. Sri Shankar, who is at present practicing in Kannur. Sri Shankar also has done his cornea and refractive surgery fellowship from Aravind. Welcome, Sri Shankar. So without much ado, let us go to the session. I invite Dr. Vanathi to start his talk.
Thank you, Dr. Vinay. Am I audible and visible?
Yes, ma'am.
Okay.
Very clear.
I think we'll move on from that interesting session on bacterial fungal keratitis to an overview on viral keratitis here. I have no financial interest. At the outset, I wish to thank the Kerala Ophthalmic Society and the Kannur Ophthalmic Society for making me part of this wonderful session and taking me aboard a digital platform of such illustrious academicians and clinicians. Thank you once again. So we'll directly delve on to our subject here. So what are the differences as compared to bacterial and fungal keratitis when you're looking at viral keratitis? Its chronicity. It tends to have relapses, can be more sight-threatening and painful, and has a strong tendency for recurring stromal and endothelial diseases. It results with significant corneal haze, opacifications, neovascularization, and the tendency to remain latent in the ganglia. So these differentiated from the earlier bacterial and fungal and other variety of keratitis, which we've been listening to. Largely, you have the herpetic and the non-herpetic viruses here. Not going to make it more didactic, as most of my talk will share a large of my clinical experiences over the years from when I have been a resident and till date here. So much of this data you would be able to read in any of the elaborate publications or textbooks here. Herpetic infections are the most common of all viral infections, and the one affecting the eye is the herpes simplex virus 1 here. What are the clinical presentation modalities which we will look at is, it could be an infectious epithelial keratitis. Commonly, the earliest form is corneal vesicles when it's usually not picked up. We look at it in a dendritic, geographic or dendrogeographic patterns and marginal ulcer patterns. Stromal keratitis falls as deciform patterns. Necrotizing, non-necrotizing interstitial varieties here. Endotheliitis is diffuse focal or linear. uveitis, a combination of these which becomes a keratouveitis and a neurotrophic keratopathy. So these are the varied clinical presentations a virus can present to us when we are looking at their corneal afflictions here. Corneal vesicles or punctate keratopathies, epithelial punctate keratopathy is how the ulcers will start. And in an immunocompromised host, this coalesces to form a dendritic ulcer or geographic ulcer. So this is how within a 24 to 48 hours, you will find this symptomatic patient develop a dendritic ulcer here. And these true ulcers will extend through the basement membranes, and if they go on deeper, can result in superficial scarring here. Herpes simplex viruses are fine ulcers here, fine dendrites with the terminal bulbs here. They could be, they appear as linear dendritic raised ulcers, and there is no missing these, and they stay well with fluorescein and rose bengal. The rose bengal stains, being the vital dye, stains those ulcers which are where the virus has inhabited and is multiplying here. These would eventually progress into superficial dendrogeographic ulcers, which can remain in the superficial cornea or can have tendency to infiltrate into the deeper stroma. Marginal ulcers are again could be viral presentations and can be mistakenly treated as other causes here. So that's something one needs to look at. And remember, when you have marginal dendrites, when you have marginal ulcers, look at the immune competency of the patient here. And the marginal presentations are largely atypical viral ulcers when they have a systemically compromised host here. What are the sequelae which would happen following an infectious epithelial keratitis? It can heal completely, and when superficial, probably may leave a minimal scar or may not scar. But when it's infiltrated beyond the basement membrane and gone into the anterior stroma, it can lead into a epitheliopathy with slow healing here, can progress into stromal keratitis, which can be an infectious component or an immune component. Ultimate healing is by corneal scarring, and you have ghost figurings or you have coin-shaped lesions depending upon the initial phenotype of the ulcer pattern here. A typical look of an early herpes simplex virus dendrite here. Look at the fine dendrites here, some parts staining here, and the terminal bulbs which you can pick up. These are all pictures which I had taken of some of my patients when I was doing my senior residency here. I'm happy to pull them out for you, and you might have seen them in a lot of presentations earlier. Infectious spread into the deeper stroma results in stromal keratitis, and this can be directly from an epithelial or dendrogeographic ulcer here. It can be the non-necrotizing type or the necrotizing type, and as we all know, this is when the HSP DNA is infecting the stromal tissue here. The necrotizing progresses rapidly to significant corneal thinning and perforation, and can mimic and can get secondarily infected and mimic a bacterial ulcer as well. So that's when a clinician looks at an ulcer at this stage, can commonly misdiagnose it as a bacterial or other ulcers caused by other organisms. Immune ulcers are pretty easy to pick up here. And this is an immune response to the herpes simplex virus, which is invading the anterior stroma, which is either by viral reactivation of the latent herpes simplex in the sensory nerves here. And Descemet keratitis is an immune form of stromal keratitis here. It could have varied patterns such as diffuse multifocal here. And when associated with an anterior uveitis, then is when you're going to suspect the strong occurrence of an endotheliitis as well in these guys here. Some clinical pictures here for you to look at and see how a necrotizing stromal ulcer here is rapidly progressing to severe thinning and perforation here. A chronicity, a chronic ulcer, a chronic epithelial stromal. So you're having a combined component of these here. And an interstitial, you could see probable several recurrences in this patient. And when you see a patient who's had recurrent episodes of epithelial stromal combined disease, then this is a typical picture which you would see. And this is a relapse which the patient is having, and you probably will need to take him for a surgical intervention. more such clinical pictures here, and a rapid perforation with the extrusion of the anterior chamber contents here. Pretty much when you see a patient in this stage, you know that their results for penetrating keratoplasty are not going to be particularly favorable here. Herpetic stromal keratitis tends to recur. Being a type 3 mediated immune response, as I already pointed out, can have a focal, multifocal, or a diffuse pattern, can move on to include the deeper stromal layers when the chances of perforation become very high, tend to have a prolonged course, more refractory to treatment here. These are again a few pictures of dendritic ulcers which moved on to take a dendrogeographic pattern here. Here you could see the bed is not staining so much with rose bengal, and the margins are staining, which means you do have the infectious particles in the adjoining epithelium, which is moving on and is pretty much an active ulcer. Here you have the rose bengal staining the bed of the ulcer, which means it's pointing out into a deeper involvement or a movement into the deeper stroma of this particular infection here. More clinical pictures, and this is a characteristic descemetocele formation here when you're having a necrotizing viral keratitis limited to the anterior layers, and it's just sparing the descemets here, and you could see the surrounding infiltration as well in this clinical presentation. So deciform keratitis is very easy to pick up. Most of the times the patients are not aware, do not have much pain, and come to you once the vision is diminishing. They do have photophobia, and a closer look would see a significantly edematous cornea here, which affects the vision. Several of them do resolve without causing much of stromal scarring, and you might pick up a scar such as this in a patient who's had an earlier immune response here. When you're looking at a herpetic endotheliitis, what you would see is that the endothelial affliction is predominant. This is a type 4 immune response to the herpes simplex virus. Could be an infectious component as well here. This is studded with a lot of KPs here. The corneal edema might be lesser, but the anterior chamber reaction tends to be more virulent in these cases, and would indicate the need for starting the patient on oral antiviral therapy along with topical steroids and a close monitor here. When there is significant amount of stromal involvement, along with an anterior chamber reaction, that's when you suspect a keratouveitis, and a cursive glance might make it look just like a deciform keratitis. A closer examination with a comprehensive slit lamp biomicroscopy will help you to look at these patients and differentiate herpetic keratouveitis here. An associated iritis trabeculitis is particularly common in these scenarios, and a raised pressure is something which you would look for and would want to treat to decrease the pain in these patients here. So a few more pictures of patients presenting with viral keratouveitis. This is pretty much straightforward, where you are seeing an epithelial defect on a few epithelial infiltrations, a stromal haze, and studded fresh keratic precipitates here. This is a picture which looks like just a focal endotheliitis, but when you look closer here, you could pick up all the virulent KPs, and the patient is moving on to become a keratouveitis in this particular case here. So how do we diagnose these cases where you probably do not where you cannot take an epithelial scraping for these patients here? So some of our work from our center looked at the role of PCR and immunofluorescence in diagnosis of herpetic stromal keratitis and endotheliitis. And PCR is definitely in as a more sensitive test than other conventional laboratory tests for establishing diagnosis in these cases here. When do they help? They help when you cannot probably take an epithelial scraping to look at a direct immunofluorescence of these virus particles here. And they do help and give you a definitive diagnosis for the viral infection, be it whatever type of viral infection you are looking at. And this particular study, which looked at multiplex PCR, has established is as one of the most important, or as the most important one, which is comparable to uniplex PCRs, depending when we looked at a lot of ocular viral infections, including HSV type 1, 2, cytomegalo, varicella zoster. The positivity was around 20% in these cases, and Aqueous tap positivity stands higher than looking at positivity in tears, probably because of the lesser viral load in the tears in these particular cases here. Neurotrophic keratopathy is the next presentation in patients who have had recurrent viral keratitis, where their ocular surfaces have undergone damage due to the sensory nerve affection of the virus. You have atrophic, indolent, metahepatic ulcerations. They can tend to look like geographical corneal ulcers and can be misdiagnosed and treated with a lot of topical antiviral therapy, making the condition more worse here. But do remember the typical neurotrophic characteristics of an ulcer, and these eyes will tend to be relatively quieter unless and until you have the associated severe keratoconjunctivitis features present on. So that can become a diagnostic challenge if the characteristic symptoms phenotype is not present in these, and treated with the copious topical lubricants, remove the inciting epitheliotoxic factors, patching, tarsorrhaphy, biological tear replacements tend to play a significant role. We'll talk more about it on the newer interventions for neurotrophic keratopathy management subsequently towards the end of this talk. But amniotic membranes do work well in these cases and will help to restore tectonic integrity of the corneal stroma when you aptly time it after taking care there is no surface infection in these particular big cases here. So who are those individuals who are at a particular risk to get viral keratitis compared to the general population here? Those who have altered a stressed immune system, such as atopy, those on immune stressors here, emotional stress, sun exposure, menstruation can particularly be predisposed to infections. Those with depressed cell-mediated immunity, such as those with HIV infections, diabetes, organ transplant receipts, are a particular risk for higher infections, especially those HIV-infected patients have a threefold increase in the risk of developing ocular HSV here. What are the local susceptibility triggers? As most of us know, topical medications like prostaglandins, steroids form the mainstay for predisposing a patient to infection here. Local inflammations and trauma, contact lens wear, trauma through intraocular surgery, lasers, ocular surgeries like refractive surgery, cataract, keratoplasties also lead to or can trigger herpetic infections in the predisposed individual. This is a particular case of an elderly individual with systemic lupus erythematosus who presented with coarse peripheral dendrites and in the periphery. And this is what I wanted to point out is the atypical dendritic presentations in immunocompromised patients here. So what are the clinical concerns? So far, we've been talking about the straightforward viral presentations, but how does viral keratitis touch us largely in general practice in ophthalmology? The post-cataract surgery reactivation is something which most of the cataract surgeons or anterior segment ophthalmologists are particularly interested in. And some of them do start antiviral therapy for these patients in the immediate post-op. I do refrain from starting antivirals for routine cataract surgery in patients who have not had recent episodes, but those who are immunocompromised and who have a tendency can be specific HSV triggers, and these are the cases who I keep them on closer monitor and call them off for frequent follow-ups to enable starting a systemic antiviral at the earliest indication of a viral reactivation. That said and done, there have been patients who have come back much later, an activation missed with significant opacification, losing much of their vision, which they gained following a cataract surgery. So that's something which an anterior segment surgeon needs to look out when you are looking at doing cataract surgery on a patient with a healed viral keratitis. Then looking at keratoplasty scenarios, it's two ways, viral keratitis and keratoplasty and viral keratitis. I think I'll leave a lot of this for our panel discussion here in view of the constraints of time. And we'll touch up more on this when I share some of my clinical experiences. Talking about HSV triggers, local inflammations and interventions leading to herpetic ulcers here. I think anti-VEGF injections, most of those retinal surgeons who have been giving anti-VEGFs in immunocompromised patients such as diabetics would see a larger amount of herpetic ulcers in those eyes which receive repeated HSV infections. So this is one particular report which is particularly interesting, and which I picked up following one of such cases which I did see in my clinic, referred over by my retina colleague, patient developing viral keratitis in the fellow eye following receiving an intravitreal Avastin in the affected eye with the posterior segment problems. And that's when I pulled up, and this has been described in literature, occurrence of metahepatic ulcers following intravitreal bevacizumab. Interstitial keratitis is an atypical stromal disease. This is caused by retained viral antigen in the stroma, which triggers an antibody complement cascade here. So I did show you earlier pictures on these. And to look at keratoplasty in HSV keratitis, concerns here is the disease recurrence. That's the top concerns. And there is a high association with glaucoma and graft rejection. So occurrence of doing keratoplasty in viral keratitis patients does increase the risk assessment scores of these patients here. A previous corneal infection always predisposes donor grafts to high risk, and this is when you viral therapy. How long? It still varies, and most of the studies is up to 18 months or so. I have seen recurrences occurring when the patient is on antiviral therapy, and recurrences occurring after you stopped your patients on antiviral therapy. So that is something which is of concern to most of us. But what I do see is that the severity of subsequent stromal disease is probably lesser when you take these patients on, when you do put them on long-term prophylactic antiviral therapy here. Sharing with you one particular case of my lamellar keratoplasty, patient probably with a history of healed viral earlier. And we looked at it as an endotheliitis and missed the earlier significant thinning, which was present, which I did go and look up at her ASOCT subsequently when she presented following 3 to 4 months of a keratoplasty with an infection of the host trauma here, and the graft being relatively clear here. She did heal, go back, and regained almost 70 to 80% of her postoperative vision, but promptly reported 6 months later with another relapse, another recurrence, and subsequently did lose much of her vision here. So that was something which I learned to go back and use the ASOCT and do warn these patients, and probably do put them on and keep your antiviral therapy on for these, and a high suspicion quotient for viral keratitis in lamellar surgeries. So why is this viral keratitis so worrisome? What is its pathogenesis? When it contacts an epithelial cell, it enters the cell, and from these cells, it can move retrograde into the adjoining sensory nerve endings along the axon and into the neuronal cell body. And when the virus genome persists in the neuron, it creates a latent state here. The interneurons
I think we lost Dr. Vanathi's connection. Is it me, or does it happen to everybody?
Yeah, she's not there. Vinay, Vanathi is back.
Yes, madam. We have your screen now.
Vanathi, I think you're muted.
Yeah, can you hear me now? Yes, I'm sorry about that.
Yeah.
Yeah, sorry.
You can restart.
Okay. Where did you lose me? Did you?
No, after this slide.
After this, so straight after this. Okay. So pathogenesis was what I was talking on, and when it invades the epithelial cells and can move on to the adjoining sensory nerve endings and along the axon and into the neuronal body, and that's where it stays on as a latent disease, as a latent in its latency states here, and can spread into the can have an interneuron spread going into the adjoining axons. Active viral replication occurs when it moves centrifugally down the axons and back into the ocular tissue and causing recurrent disease. And that's a reactivation state precipitated by the various virus triggers. So understanding its latency is important, that latency-associated transcripts are induce and maintain the latencies, and these do not code for any proteins here. And neuronal survival, they affect the neuronal survival, they suppress apoptosis. There is an induction of latency here, and reactivation from latency are all the molecular basis of understanding HSV latency. And during a viral latency, you have these the LATS expression decreasing, leading to a later disease in recurrence and a latency disease here. So now we will move on to see the systemic antivirals in management, and what are the head's recommendations here. So antivirals, they help in prevention of recurrent episodes, and the low absorption of oral acyclovir mandates the frequent dosing here. Valcyclovir is now used as an alternative to acyclovir here. Current treatment helps to reduce the corneal scarring morbidity here and helps the viral latency. There is a higher bioavailability for valcyclovir. And what are the equivalents? 800 milligrams of acyclovir 5 times equals 500 milligrams of valcyclovir. And 400 milligrams of ACV includes 500 milligrams once daily of valcyclovir. Famciclovir is something which can be, it's dosed as 250 to 500 milligrams thrice a day. What we have as a newer antiviral is the prodrug. The newer antiviral prodrug, valacyclovir, has a better ocular penetration and dosed at 1 gram thrice a day here. And the zoster eye disease has extended the use of oral valcyclovir for prophylaxis in cases of herpetic keratitis here. Oral valganciclovir is the newer medication which is indicated in cytomegalovirus stromal keratitis. Remember, does have systemic side effects, particularly aplastic anemia. A little more on ganciclovir. It has an effective penetration through the cornea, can maintain good therapeutic levels in the deeper structures of the eye. There is a direct incorporation of this antiviral into the antiviral medication into the viral DNA, and the strands and causes breakup of the viral strands here. It also inhibits the viral DNA polymerase and hence affects the DNA synthesis here. Causes rapid apoptosis of the cells and used as a 0.15% gel here. Very effective modality in the treatment of herpetic, varicella zoster, and cytomegalovirus infections. The toxicity is said to be lesser here. We'll have to look at how it can be rated in terms of resistance as compared to acyclovir, as it is said to be causing lesser viral resistance here. There are a lot of these herpetic disease, heads 1, heads 2, and these can pretty much be read in most of the standard publications here. So I am going to skip much of these, but what has evolved from these is that it does really help in cases of stromal keratitis. And there is no evidence to use it in epithelial keratitis, but cases of stromal keratitis and anterior chamber inflammations, they definitely have a role and do decrease the recurrences and the morbidity of recurrences by over 50% or so here. And looking at other studies, the herpes simplex virus epithelial keratitis trial here. In treatment of acute epithelial keratitis, there is again no benefit of oral acyclovir, and a topical antiviral will suffice, and you do not need to put these patients on. But those who have had earlier episodes of stromal viral keratitis are candidates for putting them on long-term antiviral therapy as long as 1 year or 18 months here. Psychological stress has not been seen to be a particular trigger for recurrences of ocular herpetic simplex disease. Herpes zoster viruses, again a herpetic family, and can occur as a primary varicella, and recurrent infections are the zoster shingles here. A varied presentation including phenotypes of punctate epithelial keratitis, pseudodendrites, and dendrites which tend to be much coarser, larger, and do not have terminal bulbs. Can also occur as endotheliitis, uveitis, neurotrophic keratitis in chronic cases, and chronic perforations. So what you would see is when you have the Hutchinson sign positive and a virulent infection here, it could be a direct infectious lesion, but most will tend to be immune lesions here, and the anterior stroma and epithelium can be relatively disease-free here. So your treatment would largely depend upon the type of herpetic zoster infection you're seeing in these patients. And of particular interest, what we are looking at and awaiting is this multi-center randomized double-masked trial ongoing at NEI, NIH, USA, looking at the role of long-term oral valacyclovir therapy in patients with herpes zoster and how it can work as a suppressive therapy to reduce subsequent relapses in these patients. It is expected to reach us. It was expected to be completed in 2023, but the current situation has moved it further to 2024. And we'll have to wait to see what their results are and what the recommendations are going to be. Cytomegalovirus here has now been recognized as an infection, which as a virus which not only affects the posterior segment, but can cause significant anterior segment disease, and not only just as iridocyclitis, but significant CMV endotheliitis, with the characteristic or typical lesions being coin-shaped lesions associated with or without linear KPs here. So a lot of literature here from the Japanese group, from the Korean group here, and all do show that the PCR is the most effective with good sensitivity and sensitivity in picking up in the CMV DNA in these suspected patients, as most of these infections are endotheliitis and iridocyclitis. The need to pick up these is that they would tend to recur, especially if you do D-sex posterior lamellar keratoplasties in patients of healed viral endotheliitis, and they can cause recurrent anterior chamber disease leading to significant graft failures early on in your cases here. So the need to start prophylactic antiviral therapy with ganciclovir in such patients and maintain them on the therapy for a longer period of time. And mind you, being ganciclovir, oral therapy being an expensive therapy, this needs to be discussed with your patients before you embark managing these patients here. HIV infections, there's nothing new which on it, and we know they can present with case keratoconjunctivitis, Zika, keratitis, iridocyclitis, but the commonest affection is herpes zoster virus infections in these patients, which account to over 20% of the viral infections of the ocular surface in patients immunocompromised with the HIV here. Looking at COVID, all of us do know that the COVID SARS has a predilection to affect the conjunctival mucosa, follicular conjunctivitis being the most common, but literature has reported keratoconjunctivitis, hemorrhagic and pseudomembranous conjunctivitis, Kawasaki-like disease in children, and episcleritis here. So looking at the molecular characteristics with relevance to the SARS-2 virus here, among the ACE2, the TMPRS and the SINE and SINE-R receptors manifested on the conjunctiva limbus and the cornea. We know it's the AC2 virus, which is the key receptor for docking with the SARS-CoV-2 viral spike protein here. But what literature has told us is the predilection of this virus to bind with the conjunctival tissue is much less as its predilection to combine with the lung tissues. And perhaps that's why we do not see more of keratitis in the COVID patients. Here, I will not delve into the other concerns of COVID virus with relevance to donor corneas here. And we'll move on directly before I close on the novel interventions for neurotrophic keratopathy in viral keratitis scenarios. Specifically could be useful in herpes zoster keratitis patients here who do have significant keratopathy and anesthesia. And these are patients who could be good candidates for corneal neurotization. Direct and indirect neurotization techniques have been described. And you'll need to choose your patient wisely before you could have successful results for this surgical intervention, but some exciting therapy for neurotrophic keratopathy in viral keratitis scenarios. Of course, oxynervin is in, and the use of medical therapy with nerve growth factor is promising. And we still are awaiting more easy access to use this in our patients and look at our results. Adenoviral keratitis, the first stage is conjunctival, the second is corneal, and then you could move on to an immune state. So what is new in the field of adenoviral keratitis management? There can be as many as 21 different types of adenovirus and 4 different species here, which can cause your adenoviral conjunctivitis, keratoconjunctivitis. But the one which is most virulent and can cause a higher morbidity is the D type of the adenovirus. Recent literature has looked at using early povidone iodine steroid drops in the management of adenoviral keratitis. Steroid drops is not something which I do favor, but most of these studies, many of them from different parts of the world, do point out that early usage of diluted povidone iodine of 2% given on the early days along with antiviral therapy perhaps is effective in decreasing the morbidity of the disease here in these patients here. A word of caution to all clinicians is do refrain from using steroid drops for these, because most of the lesions will be self-limiting and they do heal well. And the use of steroid drops is to contain the subepithelial immune infiltrations once the epithelial lesions have healed in these patients here. The particular concern is to differentiate the superficial coarse punctate keratopathy from a microsporidia keratopathy here. So anterior segment OCT in these patients, when done early on, you would be able to see that most of the microsporidia lesions have a coarse elevated, a stuck on appearance here. And when you see them later on in the second week or so, when the earlier epithelial lesions heal, they tend to look more similar to adenoviral keratitis here. So the adenoviral keratopathies here, the surface is relatively smooth epithelial surface, and the lesions are largely subepithelial, and that would be a significant clinical differentiation in these patients. So what all do we need to look at when you are in the clinical management dilemmas of viral keratitis? The diagnosis per se in most of these cases is clinical, and we do not resort to a laboratory diagnosis unless we are looking at endotheliitis such as CMV and recurrent infections here. The role of topical and systemic antiviral therapy, the need for topical steroids, adding on topical anti-glaucoma along with them, copious surface lubricant therapy, especially in those with tendency to move on to neurotrophic keratopathy, the dosage of systemic antivirals, how long, when to stop, the indications or the newer antivirals which are now available in our armamentarium to treat these infections, and surgical interventions in eyes with viral keratitis. I do thank my senior residents, Dr. Navneet and Tanveer, who have helped me with some of the inputs about the studies in this particular lecture here. And a very big thank you and a heartfelt gratitude to RP Center AIMS, and I'm really privileged to be a continued part of this wonderful center. And thank you for giving me this opportunity to share my experiences.
Thank you, madam. Thank you for that wonderful, extensive coverage of various aspects of viral keratitis. Now, before we go to discussion, we have a short case presentation by Dr. Seema. Can you go ahead, Dr. Seema, please?
Yes, sir. Good morning, everyone. First of all, let me thank Dr. Vinay for this opportunity. I'll be presenting a case which highlights the challenges of keratoplasty for a viral keratitis. A 62-year-old female presented to me in 2016 with defective vision in the right eye for 6 years, which has worsened recently. She was already advised triple procedure from elsewhere. According to her, she had developed pain, redness, and sensitivity of light in the right eye some 6 years back, and she was treated at 2 different places. Her symptoms subsided over 6 weeks, but blurring of vision persisted, and it has worsened recently. On examination, right eye visual acuity was 3/60. This was a slit lamp picture of the cornea. She had dense corneal scarring, macular grade in certain areas, and leukomatous in some areas. There was superficial vascularization near 12 o'clock reaching up to the scar. Corneal sensation was decreased, and she had cortical cataract along with a posterior subcapsular component in the center. So a diagnosis of right eye corneal scar status post-viral stromal keratitis with cataract was made. She underwent triple procedure in January 2017. Refined size was 8.5 mm. This was the picture on the first post-operative day, IOL in situ and all sutures in situ. And she was started on topical steroids, antibiotics, lubricants. Along with that, I started tablet acyclovir 400 milligram twice a day. At 3 months post-op, graft was clear and compact, and topical steroid was tapered to 4 times a day. She was still on tablet Esivir, but after 4 months, she stopped tablet acyclovir complaining of gastritis. And she was on monthly follow-up, but the graft was doing well. After 1 year, in January 2018, her BCVA was 618 and the graft was doing well. Selective suture removal was planned, but in early February, she came back with pain, redness, and watering in the right eye. And this was the picture at that time. She was having a graft recurrence. There was epithelial staining near 10 o'clock involving the host bed also, and it was extending into the graft. And there was a dendritic pattern near the edges. Stromal edema was also present, and there was grade 1 anterior chamber reaction. So making a diagnosis of recurrence of infection in the graft, I started her on tablet acyclovir 400 milligram 5 times a day for 1 week and then tapered it to twice daily dosage. And she was also given acyclovir eye ointment, topical steroids, lubricants was continued. Response to treatment was good and she healed without significant scarring and BCVA was maintained. And so after waiting for 6 months, alternate suture removal was done and the remaining sutures were removed in January 2019. And after 1 month after suture removal, I tapered the steroid dosage to BD dosage. And she was on regular 2 monthly follow-up till Feb 2020. And then we had the COVID crisis and the first lockdown. And she disappeared for some time and then came back in June, telling that there was pain, redness, watering for 10 days duration, and she was reluctant to come because of the COVID scenario. So this time she was having a graft recurrence, which was worse than the previous one. There was a large dendrite extending into the center of the graft with stromal edema and early infiltration. So again, I started her on the same regime. And It slowly healed over 6 weeks with scarring in the center of the graft, and her vision dropped to 636. This time she continued oral acyclovir in BD dosage for 8 months. And after that, she again stopped, telling it is difficult to take the tablet. And then she was maintained on topical prednisolone acetate, BD dosage, along with lubricants. And she was on 2 monthly follow-ups. She was doing okay, but 18 months after the second recurrence, again in December 2021, she came back with pain, discomfort, and watering in the right eye of 1 day, no history of trauma, and she has not skipped the regular medications. On examination, she was having a large epithelial defect, which was mostly confined to the graft. Host bed didn't seem to be involved. So I was wondering whether there is a recurrence or an epithelial breakdown in the hypoaesthetic graft. I added antibiotic drops 6 times a day to her regular regime. I didn't stop the BD dosage of steroid, fear of losing the graft, and asked her to follow up daily. But unfortunately, she turned up 3 days later telling that husband was not well, and she was having a large graft infiltrate involving more than half the graft with melt. So I started explaining to her regarding scraping and treatment. She was already frustrated because of the multiple recurrences and long follow-up, and they were reluctant for scraping. So I referred them to a tertiary care center. She was further managed at Little Flower Hospital by Dr. David. On scraping, they got fungal hyphae and there was no growth on culture. They started her on topical antifungals along with tablet ketoconazole and tablet acyclovir. She healed medically. She came back to me after 3 weeks, but I was so disappointed to see the state of the graft. It had healed with vascularization. So the clear graft 5 years before ended up like this. So few queries to the experts. Is it prudent to go ahead with PKP in viral keratitis scars with decreased corneal sensation? And is long-term oral acyclovir prophylaxis following PKP recommended? Ideally, how long should we continue? Role of visual rehabilitation with mini sclerals in scars before going in for PKP, and how to differentiate between graft recurrence and rejection, and what next can we do in such eyes? Thank you.
Thank you, Dr. Seema. One of the most difficult scenarios any corneal surgeons will face. I hope all of everyone here will agree to that. Now, I request our other panelists to join us, Dr. Lailan Bhatt, Dr. Sri Shankar, and Dr. Sachin. Right. We have very less time for discussion. So quickly, few questions. Now, regarding the case, the first question, probably Dr. Lailan can take the question. In a case of, diagnosed viral keratitis, when will you take them up for a transplant? It is a scarred cornea, there is a scar, and obviously something has to be done for visual rehabilitation. So, recently the patient has had an acute event, which has settled with treatment. When will you, consider that patient for a transplant? Or what is the time gap that you would give? Madam, you have to unmute, please.
Yeah, you can hear me?
Yes.
Yeah. So the eye has to be absolutely quiet. So minimum 6 months to 1 year should be, and under antiviral cover.
Right. Does everybody agree to that? Is there any difference of opinion?
Should be a quiet eye, no ciliary flush, no iritis, and at least 6 months to 1 year should lapse.
I would kind of tend to agree with that. Dr. Vanathi, do you have any opinion on this?
I think I totally agree with the ma'am, and at least a minimum of 6 months. If you're looking at none-eyed patients, is when we are probably pushed to do grafts for them on an earlier, and when their posterior segments are good. But what I do look at their immune compromised status, do a risk assessment score for these patients. Secondary glaucoma concerns in these are particularly important here. So take care of these associations. And I do agree that there are eyes, and unfortunately, it is in these eyes where I think even on antiviral therapy, as you show, the recurrences are particularly higher and the morbidity is also much higher.
Right, right, agree. So you wait as long as possible. That is a
As
fine
long
line.
as possible, yeah. And I think some people do prefer to do even keratoprocesses for these cases here.
Yes.
There are a group of patients, a group of surgeons who would take them on as a primary intervention after even their first graft has failed. So, but do Indian scenarios, we are little cautious about that. But yes, that's an option when you do want to consider in suitable cases.
Now the next question which I want to put across is, when we are, forced to do a transplant in this situation, perioperatively, how will you manage the antiviral? One, do we start the antiviral before surgery? If we start, what is the dose? Is it a prophylactic dose, or do you, really give a full, anti-infective dose which is continued after surgery? And then again, how long? Dr. Sachin, can you give your opinion on this?
Thanks. Actually, as Vinay said, I mean, it's a very difficult scenario to treat. But I think at this point of time, it's easier to comment. But I think the one thing which was learned from this whole thing is we should have put that oral antiviral across the thing. I mean, rather than stopping it 3 to 4 months later, we could have started it earlier and then continued it at least for a year. I mean, she had difficulty regarding gastritis and all this stuff, but we should have looked for some kind of, like Madam said, Velasquez or some other, agents. But I mean, that is the only thing which was, we started and then stopped, and then again we had to start. And that is,
yeah. But then immediate, during the procedure, immediate perioperative rate, what is the dose that you would advise? Is it 400 milligram 5 times or just 400 milligram twice?
400 milligrams. I would start 400 milligrams BD only. BD. I would start it as BD. Yeah.
Yeah. Any other opinion? Anybody? If Seshankar is here.
Yeah. Even I think I will go with the 400 milligram BD, and probably I will start it maybe possible 1 month prior, and it will be continued across the spectrum as Sachin has mentioned, but generally patients don't comply with that. So that's a real issue.
Yeah. Dr. Vanathi,
I think
suggest what should be done?
Ideal is at least 3 weeks prior to surgery. Sometimes it's difficult to time your surgeries around here because you do call your patients perhaps just about a day before your surgery or a week before. So at least try to keep them on for about 10 days. You could start 400 milligrams twice a day, and do take your patients on. I feel we do tend to stop in a year's time, most of them, considering the systemic concerns and considering the cost basis here. But I would, in suitable patients, keep it on for 18 months, though acyclovir is a particularly safe drug to use compared to many other systemic antivirals which we need to give in keratoplasty, systemic therapies we need to give in keratoplasty.
Vinay, with your permission, may I ask?
Please.
Yeah. See, all my questions will finally come down to cataract surgery. So a case with
we will be coming to cataract surgery.
And
anyway, please go ahead.
Yeah. So the patient has disciform keratitis, treated with and it's got a mature cataract. See, the initial picture was like it was referred to me for the management of lens-induced glaucoma. So if it had viral keratitis that treated, it's subsiding. The question is, see, once the viral keratitis part subsides, when do you take up the patient for cataract surgery, and how do you maintain the antiviral oral or topical also? How do you make sure that post cataract surgery, whatever happens, it is not viral keratitis, and you have a confusion whether it's something to do with your cataract surgery? Because so how would you go about cataract surgery? Because it's a mature cataract, So the initial doctor suggested lens-induced glaucoma. You need to do a cataract surgery as early as possible. How would you go about in this particular case, or any case with viral keratitis which requires cataract surgery? How do you maintain the oral antivirals and the rest?
Madam, would you like to take that question? No. So I believe there are two-part question. One, if I'm correct, sir, you were asking that there is a viral keratitis going on and the patient has along with it a lens-induced part which is causing the problem, like glaucoma or whatever it is, right, sir? And the second thing is, in a case of established viral keratitis, when you plan for the cataract surgery, right? If I'm not mistaken, these are the two parts of the question.
Yeah.
Now, well, if I may answer the first question, combined case, well, the lens-induced patch which needs to be addressed immediately. It's a kind of emergency for the eye, and you don't wait. You give start full dose of antiviral. You have to operate, take the lens out, and then you hope to get a good outcome based on that, right? And the second part, in an established case of viral keratitis, like keratoplasty, which we're discussing, you wait as long as possible. Okay, at least 3 to 6 months minimum of quiescent eye. Then only you consider any form of surgical intervention. Madam, your opinion, please.
Yes, I agree that when you are looking at a case with a keratouveitis going on because of your phacolytic glaucoma here, and you are within the period where you would want to consider cataract surgery not advisable. And when you're pushed into doing this, then you would expect a higher amount of inflammatory component in the postoperative phase following your cataract surgery. So you need a closer monitor on these patients, but be careful that the epithelium and the stroma are not so affected in these patients here. So that's when you would not want to do cataract surgery, but a 6 months period or at least a minimal 3-month period of no inflammation due to viral keratitis is mandatory and desirable. And patients with systemic triggers, these are the ones which can have early recurrence of the disease following cataract surgery. And these are the candidates whom I would probably put on prophylactic antiviral therapy for up to 3 to 6 months following cataract surgery and call them more frequently to assess their cornea status.
And what will be the dosage of the prophylactic?
400 milligrams BD. We're using acyclovir, and if you want to use valcyclovir, it's once daily.
Thank you, madam. Now, if I may take, before we move on, one of the questions which Dr. Seema has put across, whether we should use mini-scleral before surgery. From my side, I would say we should exhaust all options of visual rehabilitation in these patients before we touch this eye. Mini-scleral, RGP, whatever is possible. If they are giving a reasonably good vision, ideally, better to avoid any kind of surgical intervention in these viral keratitis. Now, moving from this, sorry, I'm cutting short the discussion much because of the lack of time. I have hardly 3-4 minutes. That's what, instructions which has been given to me. The most common scenario which all of us face in our clinical practice is adenoviral keratoconjunctivitis. Very, frustrating disease in many cases. So there are certain pertinent points which we have to, highlight here. I would like to start by asking Dr. Lylan again, is there any role for any topical or systemic antiviral agents in these cases? Common viral conjunctivitis, which presumed to be adenoviral.
In presumed adenoviral, once again, only lubricants and support therapy, like paracetamol for the fever or cold compress. I would initiate topical steroids only if extremely symptomatic patient with severe injection, maybe a pseudomembrane and visually incapacitating subepithelial infiltrates. Otherwise, no steroids, no antivirals, only ocular lubricants, maybe vitamin C paracetamol, cold compress, ocular hygiene.
Thank you, madam. So I just want to bring out this point because a lot of times when we see people, have been using antiviral in the terms of too early ointments and all in these cases, and actually rather than doing any good, it induces a lot of surface toxicity. So it is no role in viral conjunctivitis. Now, Dr. Sachin, Dr. Lylan touched about topical steroids. Okay. I mean, when will you start steroids in these cases? What is your, indication in these cases?
Definitely, steroids is it's a no in the initial phases. I mean, once it is like again the usual indications, like if the SPK is involving the visual axis and the patient is really bothering you and sitting on your head after, then is the time when we actually think about starting the steroid. Otherwise, the usual indications only. I mean, these are the three I would say. If it is coming to visual axis, and if it is like, that is it. But my threshold will be very low actually. I mean, because we have seen the worsening of symptoms after starting steroids. Yeah, thanks.
Right. Dr. Srishankar, there are a group of patients. Srishankar is here, right? There are a group of patients where every time you taper steroids, there is a recurrence of keratitis, which happens in probably a couple of weeks after stopping. So how would you address these cases? Do you continue with this, or do you
only have one answer?
Use any of this?
Sorry, I only have one answer to that. Once a patient is hooked onto the topical steroid, they are actually, it's very, very difficult for us to take them off steroid. So my typical thing is that it may stretch on to maybe months and even years, and I explain to the patient. And many of my patients are still on probably loteprednol once a week, and it has been going on for like months or years. And of course, with you care about taking intraocular pressure and all, but it's very difficult to wean them off steroids. And so I tend to continue with the steroids indefinitely, a low, softer steroid.
Right. Madam, Dr. Vanathi, what is your opinion in these cases? Do you continue to put them on steroids, or do you prefer to shift them to one of the so-called steroid-sparing agents, like topical tacrolimus or cyclosporin?
Yes. So you do keep them on once daily low-dose, low-potency steroids for as long as possible. And when they are having a recurrence, what you need to look at is they're having an epithelial recurrence on these patients here with your neck. And I do, after a period of 6 months interval free, then add on, if you are looking at tacrolimus, then the surface toxicity of tacrolimus is particularly high. So I do use them on the lid, but I don't use them so much for viral recurrence, keratitis recurrence here. And cyclosporin 1% QID. This is a medication which we would use on in many of the patients to prevent graft as a prophylactic measure for graft rejection on those surfaces where you do not want to give steroids for a long term of time. So that's an alternative which you can consider here. But the surface stinging is particularly high. You are using a 1%, so it's not an over-the-counter, and you will have to get an in-house pharmacy to prepare these for these patients. These do help as last resorts in these dire eyes.
Right, ma'am. Thank you, ma'am. Dr. Sima, do we have some more time, or is it time to
No, Vinay, I think we'll move on to the next session. And Vinay and the panelists, please see the YouTube chat box and reply to the queries there itself, in the chat box itself, as it's going on.
Right.
Thank you, Vanathi.
Thank you, madam.
Thank you.
Thank you, Vanathi,
all
madam.
the panelists for this wonderful session. Thank you.
Thank you, Vanathi, madam, for that wonderful pictures and extensive talk. Thank you, Dr. Vinay sir, Dr. Lylan Bhatt, Dr. Sachin, and Dr. Srishankar. So the next session will be on the peripheral ulcerative keratitis, which is a diagnostic dilemma for most of the general ophthalmologists. This session.
Continue, Sujita.
Yeah. This session will be headed by Dr. Anil Radhakrishnan, who is an associate professor, AIMS Kochi. Sir's areas of interest are corneal infections and anti-segment imaging. He is the first surgeon in the state to perform DALC, Descemet, and DASEC. Over to you, sir. Sir?
Yeah, I'm very much here. Yeah, can you, yeah, fine. Yeah, so good afternoon, everyone. Sorry, good evening, good morning, everyone. It's 11:15 now. Okay, so welcome all to this great session on peripheral ulcerative keratitis. So I really thank the dynamic Ksos committee, leadership for giving me this opportunity to do this particular program. I really appreciate my energetic great friend, Dr. Srini, who's the scientific committee chairman, who has been really pushing everyone to do this particular program. And he has been instrumental in really pushing Kannur Ophthalmic Club to do it. And they've done a brilliant job. I thank Dr. Simi and Seema for their excellent background work they have done. So, as I mentioned before, even though we call this PUK, the session on PUK, we will be basically dealing with peripheral ulcerative, not just peripheral ulcerative keratitis, we'll be dealing with all peripheral corneal diseases with the interest of everyone in mind. PUK is a very niche, niche thing, which is practiced by some section of cornea specialists. So I don't think it'll be applicable to everyone. So keeping that in mind, we have included the peripheral corneal diseases. We'll begin the session by a keynote by Dr. Somsheila Moorthy on peripheral ulcerative keratitis. So Dr. Somsheila Moorthy, can I share my slides?
Please share, Anil.
Yeah.
With you, right?
Yeah, it's here. Yeah. Okay, I think there is some issue. I'll just tell that Dr. Somsheila Moorthy is presently the head of the Department of Cornea and Anterior Segment Services at LV Prasad Eye Institute. It's one of the premier institutes in India, not just in India, but all around the world. The fact that she's the head of the department tells you that she is scientifically, she has proved her brilliance. And she has under her hat more than 150 peer-reviewed publications and 8 book chapters. She has done multiple research studies in the clinic and outside, and while doing a fellowship, I've seen her doing it. She has been the reviewer for a lot of major international journals and has been the Achievement Award, American Academy of Ophthalmology Achievement Award recipient in 2019, I think, and in World Ophthalmic Society meeting also. So with these few words, I'll welcome Somsheila to open her presentation and start with the program. I apologize for the delay in starting the events.
Thank you very much, Anil. Very good morning to everyone. And I really want to place on record my appreciation for the extremely dynamic cornea meeting going on today. I hope it has a lot of viewership because the topics offered are just excellent. And I was enjoying the previous session that I had joined in, listening to all the very lively discussion and very practical discussion, I think. So I'm going to continue hopefully with that trend in my talk. And I don't want to start without thanking the Kannur Ophthalmological Society as well as the KSOS for so kindly letting me talk in this session. And thanks to Anil for putting this together. So with that, I'll go on to my talk. And Anil, I'm going to share my slides, if that's okay.
Yeah, please.
All right, so I'm going to full screen mode. Let me know if you can see them, the slides, and if I'm audible. And I also put the subtitles in case can't be understood by anybody.
Okay. That's nice of you, Somsheila. You are very well visible and audible.
Also, yeah. Also, in case I suddenly press mute and then something like that. So just let me know. Sometimes I go on rambling, and if I've lost my internet connection, so I wouldn't know that. So you'll have to call me or something in case that happens.
You will do that.
That's the only problem with Zoom meetings, I think. So exactly as Anil said, that mine is going to be a talk on PUK, not for the super cornea specialist, or it's not the niche PUK I'm talking about, but it's going to be an everyday guide to managing PUKs that we might end up seeing in our clinics. Hopefully not as advanced as the picture that I've put here, just to alarm all of you, but hopefully much milder conditions than these. So what is P, U, and K? Obviously, any condition that can cause peripheral ulceration of the cornea. And this is a very long list. Not just when we say PUK, we think of systemic diseases, we think of Moorthy's ulcer. So they are there, of course, but we also should think of the simpler, the more humble marginal keratitis and several other PUK-like lesions. So these can include various infectious etiology, there can be inflammatory etiology, not immune-mediated, but inflammatory, and other conditions that can disguise themselves as the classical PUK. So when we talk about the classical PUK, what we refer, all of us as ophthalmologists, and if you look at the textbooks, so when you say PUK, you automatically switch on to the classically immune-mediated PUKs. So these are, of course, rare, luckily, and the immune-mediated, so they're caused purely by inflammatory etiology, not really primarily driven by infection or any other thing. And they can be either ocular alone, so you can have an ocular immune-mediated disease alone, or they can have systemic autoimmune association. So you have certain diseases, we know most of them, they have associated ocular components. So we'll be coming to that a little bit later. And if they have systemic autoimmune diseases along with them, or even if they don't have, but they have a particular kind of a clinical picture, then this particular sub-entity would have a high association with connective tissue disorders. For example, the clinical pictures that you see, the one on the top right hand of your screen, is a patient with this peripheral crescentric ulceration and overhanging edge. So there's no prizes if you've guessed that it is Moorthy's, very classical Moorthy's. Whereas the picture at the bottom of the screen, it shows this peripheral ulceration and whitish looking infiltrate, but it also shows an extremely congested eye. So in fact, this is a patient who has rheumatoid arthritis as well as scleritis. And this patient, we found out the reverse way. First, the patient came to us, then we investigated, and we found out that the patient has all the systemic problems as well. So in the second instance, the connection with systemic disease is very high, maybe 50%. So also in the second instance, the ocular manifestation can precede the systemic disease. So that is the importance for us as general ophthalmologists to be able to categorize the diseases, whether they need to be referred further ahead down the stream, whether they need to be referred to a very niche kind of a cornea specialist, or whether you need to refer them to the rheumatologist and so on, or can we treat them by ourselves? So coming to the clinical features of all the PUK and the PUK-like diseases. So they would be unilateral most of the time. They can be bilateral also, but that's pretty rare. If they're bilateral, think of either an etiology that affects both the eyes simultaneously, or think of some systemic condition as well. If the classical picture, as I showed you in the previous presentation, as well as this picture here, that it's crescentric because it goes along the limbal vasculature. That's why it takes up that crescentric kind of a shape. And it's along the limbus, as I said, and it starts off as a corneal ulceration. There can be infiltrate at the advancing edge, which is very typical of where they have infectious etiology, non-infectious etiology. So there'll be an infiltrate at the edge which is advancing, and the edge which is receding is ulcerated, and the very far peripheral edge will start showing some signs of healing. So that's how you see it. And the spread would be all along the limbal girdle, the limbal vasculature. So some of the lesions, especially the non-immune mediated, for example, if you have infectious, say viral or sometimes fungal, they'll start spreading centrally also. They won't respect the circumferential distribution alone. They'll come central also. So the other features that are very typical are that if left untreated, they will spread, they will cause thinning of the cornea, and the thinning can be so bad that they can have perforation also. They will, if it's not classically Moorthy's, but if it's some infection, it can involve the conjunctiva, it can involve the sclera, you can have an infectious scleritis, for example, if you have a peripheral lesion due to infection. Occasionally, there could be anterior chamber reaction. For example, I'm showing in this picture here, which is a patient with Moorthy's. you can see that there is some pigmentary changes, which is due to older inflammation in the eye. This is just because the inflammation is going on for a while. But sometimes if you see hypopyon and severe inflammation, then you might suspect that it could be an infectious etiology. So here is a patient who presented to us with a bilateral peripheral ulcerative keratitis. This is quite atypical. So this was a 47-year-old lady. Systemically, she had no symptoms of any other disease and presented with a sort of a slow, over a month kind of a history of a sort of a low-grade redness and pain in both the eyes. And the top picture is of the top 3 pictures are of the right eye. So she presented to us with quite an extensive thinning way here. There was in fact a perforation. And so we went ahead and we did a tissue adhesive for this patient, and she did okay with that particular intervention. In the left eye, when she presented to us, she has a more extensive perforation, as you can see. And so what we had to do for the left eye is a small patch graft for the left eye. That time I used a corneal tissue and patched that eye. And since then she did well, she stabilized. But in addition to all this, we also investigated the patient thoroughly, and we saw that her RA factor was positive, though she did not have systemic symptoms of that. So we started her on oral steroids, gave her pulse steroids before we took her up for surgery at the first instance. And also we continued her on azathioprine, which is an immunomodulator. So some atypical features for this patient, why it is not Moorens alone, is because of this congestion that you can see around the area of the peripheral ulceration. Even in this picture, you can see that as well. So she had a scleritis as well as a PUK. Even in the right eye, which was less affected, she has some congestion over here, which is very local, and she had a scleritis. So these RA patients typically have very low-grade kind of inflammation. And this is the hypopyon that is there in the worst eye. And so because of severe inflammation, the patient can have hypopyon, but we also took scrapings. We tried to rule out secondary bacterial. We tried to rule out viral etiology as well. So everything else, it was negative. So then we sort of presumed that she has an RA positive, a bilateral PUK, and we're treating her since then with that. And she's, luckily for us, she's doing well. So coming back to the General Ophthalmology Clinic, what is the relevance? So the relevance in terms of the frequency or the prevalence of these diseases. Luckily, immune-mediated PUK is pretty rare. The case that I told you is less likely to walk into all our clinics on a regular basis, but it's not zero. So you may see such a patient. On the other hand, Moorens ulcer is slightly higher in the population, and for some reason in India it seems to be fairly prevalent, I would say. So each and every one of us in our general ophthalmology clinics are very likely to see cases of Moorens ulcer, at least not very frequently, but at least a few in our careers. Whereas on the other hand, the PUK-like lesions, which includes the entire bunch ranging from even a simple blepharitis causing sort of a PUK, or a contact lens induced peripheral infiltrative lesion causing a PUK, and so on. So the PUK-like lesions, all of us will definitely be seeing these cases, and we should be able to manage this third category very well. So the last one, the one associated with systemic diseases, are going to be extremely rare, and probably unless you are very well versed in dealing with them, probably what I would suggest is that you can definitely recognize these entities and refer them to the next level, because you would need to tie up with a rheumatologist or a physician in order to treat these patients for long term. So therefore, to manage these patients is basically to locate what is the etiology. When I say locate, because we want to know, is it a local condition or is it a systemic condition? If it's a local condition, it can be infectious or it can be immune mediated. So we differentiate between these two. If it is a systemic condition, once again, it has to be differentiated as, is it immune mediated versus a non-immune mediated? And what is this non-immune mediated? We'll come to this. So this patient again is a case of advanced Moorens ulcer. It's not very difficult to make it out if you've seen cases of Moorens ulcer. They'll come like that to us with one eye at this stage and the other eye may be an early Moorens ulceration. So this patient also, I think, needs a specialist referral, because this patient would need oral immunomodulators and therapy for a fairly long time. And then after everything is quietened down, then you need to address this situation. Maybe consider doing a large corneal graft or something like that. But if I was on my own without the help of other colleagues, probably I wouldn't be managing this case. So whereas the picture on the bottom is a local cause, but it's not Moorens ulcer. So this patient actually had bacterial keratitis, which we had diagnosed, and then it very rapidly thinned out, and there was a perforation over there. So this is a perforated corneal ulcer. So this definitely many of us can manage. Maybe for this particular perforation, you can try tissue adhesive, bandage contact lens, or you can try a Tenon's patch graft and take care of the bacterial infection in the case on the lower part of your screen. And once these keratitis lesions resolve, then the matter is not too difficult because there's a lot of central cornea available. The patient may even have a reasonably good visual outcome, which is what we had for this particular patient. So coming more in detail to the local causes, which will include infectious causes, as I mentioned, like the example I showed you, which can be any of these non-infectious or non-immune mediated causes. This I told you I'll talk about. So you can even have trauma, for example, thermal injury, and there could be melting of the cornea. If the patient comes to us a little bit later in the stage, we might only see the peripheral ulceration. We might not know about the initial entry level, how the patient had, what injury it was. So we must take a very good history. The lids and eyelashes, if they're misdirected and they keep on traumatizing one area of the cornea, they can lead to a sort of an ulceration and a downhill course. So recognize that. There can be neurotrophic keratitis, which can lead to melting again, or lack of sensation can lead to lack of wetting. And again, there'll be a sort of a PUK-like picture. And certain neoplastic conditions can also mimic the peripheral ulcerative lesions. And of course, autoimmune local causes, you have Moorens. Coming to the systemic causes of sort of PUK-like picture, we have immune mediated, of course. We have some dermatological conditions, and we have some systemic infections, which I'm going to come to in the next slide. So just to complete the local causes of PUK-like picture, again, I talked about bacterial, just listing out the viruses and acanthamoeba as well as fungus. And the non-infectious, I talked about various chemical injury or thermal injury and so on. When you complete the list of eyelids or lashes, you can have entropion, ectropion, etc., exposure, trichiasis, many such conditions. So very thoroughly inspect the lids and lashes. Neurotrophic keratitis can be HSV related, as was the discussion in the previous session. And apart from Moorens, even very bad severe allograft rejection and severe use of steroids with the graft melt can sometimes resemble a peripheral ulcerative like keratitis, but it's very rare. So which brings us to the systemic causes of PUK. This gets a little bit tedious for you to listen, but just to complete the list. So there'll be several such systemic causes. The commonest of which, really speaking, what you need to know about is that rheumatoid arthritis and granulomatosis polyangiitis. These are the top two conditions which are associated with PUK. So when you have a patient with some systemic etiology, or maybe a young patient, or maybe an elderly patient with some arthritic kind of history, so look for these two conditions. You may not have to manage the patients yourselves, but it would be good to know and good to refer these patients. Then, of course, you have rarer conditions like relapsing polychondritis, SLE, PAN, and Sjogren's syndrome. So these are some of the other causes that can lead to PUK, and these are also vasculitic diseases. Coming to the few other conditions, dermatological conditions, there are probably two, that is the cicatricial pemphigoid and those lesions, and Stevens-Johnson syndrome. So these are two dermatological conditions to complete the list of systemic causes of PUK or PUK-like lesions. A few more: inflammatory bowel disease, systemic infections. So you can have tuberculosis, which is systemic infection, but you can have PUK in the eye, and you sort of do a very thorough workup. And finally, when there's nothing else but patient has systemic tuberculosis and mantle is highly elevated, sometimes by treating the tuberculosis, you can have evolution or resolution of the condition. And you can also have systemic varicella zoster virus infection. You can have AIDS patients presenting with PUK. Certain malignancies, as I mentioned. So let us make this a little bit more relevant to us, and I'll discuss two cases that we have, that I have for this presentation today. The first case is a 27-year-old who presented a bit before lockdown, and he came with a similar episode of what he had, that is redness, burning, watering for 4 months in 2017. That previous episode had healed with oral steroids, that's what he said, and systemically he was fine. But he had this condition going on for 4 months. This is the worst eye, that is the right eye. What it shows to us in the diffuse image, you can see that a lot of vascularization, central part looking sort of an island of tissue, which looks like thicker with the stroma in there. And peripherally, he has a very thinned out tissue. So it was a very messy looking eye actually in the right eye. Vision was hand movements, the corneal sensations were intact and tremors were normal. It didn't look like any infectious etiology actually. The left eye showed this peripheral area, which the patient mentioned that the previous time in 2017 was also affected. And it showed a little bit of thinning when you looked at the slit here. So we diagnosed the patient to have maybe a resolved PUK in the left eye, and in the right eye, maybe a very advanced peripheral PUK, which has now moved centrally. So what we did for this patient is that we stabilized the patient. We investigated him, first of all, to make sure we're not missing any other disease. And we finally diagnosed, as I told you, that the patient to have as advanced Moorens sort of an ulceration. And peripherally, there was iris tissue as well. So we thought that there was a seal perforation. And he was a very young patient with aggressive disease. So we immediately started him on oral steroids, and we also added immunomodulators or steroid sparing therapy. And we were planning that as soon as the eye becomes less angry, then we'll intervene for improving his vision in that right eye. And tectonically, it was stable. So we didn't think that we needed to do anything much. So this is within 3 weeks of starting aggressively IV, MP, as well as oral steroids. And also we started methotrexate. You can see that the cornea looks much better. The central contact lens sort of cornea that is remaining now is looking like this. Peripherally also, all the inflammation seems to have subsided. Only the thinned out areas are much more prominent here. So we were a little happy that the patient is stable. This was 8 weeks after starting that. You can see some clearer areas of the cornea. This area is looking like a Descemet seal. So we are a little apprehensive, but still the patient symptomatically much, much better. But unfortunately, our hand was forced because 3 months into the therapy, the patient came with this large area of perforation. What you're seeing here is a very rounded perforation. Iris tissue is actually plugging it. So we underwent a large graft for this patient under general anesthesia. And this is a 3-month post-op picture. So he also subsequently underwent cataract surgery, and he's waiting for an optical keratoplasty, maybe a DSEC for this particular patient with secondary IOL. So this, at least the primary disease is controlled, but we know that Moorens is something that can keep recurring. So we're keeping this patient, maintaining this patient with oral immunomodulators. So to summarize this first case, it's a case of aggressive Moorens in a young patient. So it definitely needs long-term immunomodulator therapy for the affected eye, as well as to protect against having the disease again in the fellow eye, which is more important. So we chose methotrexate just because it's cheap and it's effective, but it may or may not be adequate. So if the patient was affording, then we could probably have gone on to biologicals such as rituximab, which is more likely to give us a long-term sort of a remission for this patient. Coming very quickly to the second case, this is a 58-year-old lady who had symptoms for the past month and a half. She was being treated elsewhere as infectious keratitis and had undergone scrapings also 2 or 3 times, which was negative. And she was on a lot of antibiotics and many other medications. So we thought that it didn't really look infectious, so we stopped most of the medications. And the patient was giving a history, and she gave this history to everyone, that she had rheumatoid arthritis, and she was on treatment for the past 20 years with several agents. So we also did 1 round of corneal scrapings just to establish that there's no infection. And once it was negative, we stopped everything else except to keep the patient on topical steroids. We thought that this is a manifestation of the systemic disease, that the PUK, which is looking more advanced now, and we gave the patient IV methylprednisolone 2 doses. And also we applied tissue adhesive on this thinned out area and maintained the patient on additional oral immunomodulators. Apart from what the rheumatologist was treating the patient, we asked them to add additional immunomodulators, and the patient was started on mycophenolate mofetil and is doing very well. So this PUK portion healed very well, very satisfying, and it's scarred with reasonably good vision for this patient. So in a sense, we of course need to have history of the entire clinical course of the patient, and systemic disease, we should not disregard that. Treatment history is useful because for the previous patient, we thought that the systemic treatment was not adequate in spite of that she had ocular disease. So we requested the rheumatologist to appropriately step up the treatment for this patient. And the systemic investigations for the earlier case I showed you, the lady who came in first to us with bilateral PUK. So we need to start off with the systemic investigations looking for these particular entities. And of course, we have to have all the time a dialogue with the rheumatologist or the physician who's treating the patient. So now we looked at the hardcore or the more sort of PUKs which we classically think about, but how else to approach these patients, and where do I as a general ophthalmologist come in? So we discussed about how several infections could be microbial keratitis that need scraping, and I harped about how we need to rule out infectious etiology, because the treatment is the reverse. For infections, you need to use the antimicrobial, whereas for the immune mediated, you need to use steroids. So we can't sort of miss, or we can't falter over here. And sometimes it may be neither of the two. It may be something very simple like ocular surface problems, as I mentioned, the trichiatic eyelashes or the lid intern. So we have to make sure we're not missing out something like that. And I'll come to a couple of examples of ocular surface diseases. This particular patient here is a rare cause. So this patient actually had an ocular surface squamous neoplasia. We did not know in the beginning. In the beginning, we saw only the corneal part. We misdiagnosed thinking this is a PUK. And only later on, after a couple of rounds of biopsy and after a couple of rounds of going wrong, we realized that the patient actually had an OSSN. This example over here, the patient was being treated as PUK and only on steroids, but this turned out to be a case of necrotizing keratitis due to HSC. And only when the antivirals were added to the patient's treatment did the patient start improving. After that, the patient did have a perforation, required a tissue adhesive application, but ultimately stabilized. So what are some of the PUK-like conditions? I'll just come to them quickly. And it seems very simple now, but you'll be sort of surprised how often we get referrals for these patients. So just keeping this classical Moorthy's ulcer as your reference base. So even something as innocuous as contact lens-induced peripheral keratitis. So patient uses contact lens or overuses, you might say, and develops these multiple peripheral sterile infiltrates. So a classical marginal keratitis. So sometimes you get a couple of referrals of these patients as suspected PUK. So just ask for history of contact lens usage, and you know that it's a toxin buildup or the staphylococcal entity that causes it. So I already talked about this patient of OSSN. That is, of course, luckily for us, it's very rare. But sometimes you can have patients with PMCD. And you know in PMCD how in the far periphery, you will have this thinning of the cornea. So here there is ectasia and bulge with the cornea looking very clear. But in the far periphery, there'll be thinning. And these patients are also sometimes sort of thought to be PUK, and we've had referrals for even pellucid marginal corneal degeneration. It seems unlikely that you might miss this, but sometimes it happens. So we discussed about perforated corneal ulcers, and sometimes these can be initially thought to be sort of a PUK, especially if you're sitting in a tertiary care. This is what happened for this patient. Was first diagnosed as PUK, and then afterwards later the diagnosis was revised, and we thought that we're looking at an infectious entity. And this is the advanced Moorthy's ulcer. So this really, in our center, nobody would miss this. But when you see this patient in your clinic, you might just wonder, what is this bizarre looking cornea? So this is typically what happens in end-stage Moorthy's. So you will have the so Moorthy's starts in the periphery. It goes on eating up the stroma. So what you see is the Descemet membrane, which is barely able to hold the iris tissue. So you have staphylomatous formation. The conjunctival epithelium has grown over, bringing along with it the blood vessels. Wherever the remaining stroma is present, that is where the inflammation is still going on. So the inflammation is still going on in the central area of the stroma. And this is that overhanging edge that you see. What do you do for this patient actively? Probably nothing much. The immunomodulators and so on you need to use. And sometimes we just very carefully excise this tissue to avoid that continuous nidus of inflammation for these patients. So excise it and just apply maybe pottery or amniotic membrane over the surface and quieten the eye before we proceed with any vision restoring procedure. If this patient presents with a large perforation, which is also quite likely, then your hand is forced and you will have to do keratoplasty for these patients. So this is what I said about ocular surface problems. So this patient also was referred to us as PUK. But the first thing that strikes you when you see the patient is, yes, you do see the peripheral thinning, but you see that very lusterless look of the eye. So you see the cornea, you see the reflex of the slit lamp beam, and you see how it looks very dry. So the first thing that strikes you is how dry the eyes look. Even the lower tier meniscus is barely there. And this was actually a case of keratoconus sicca with 0 Schirmers. And of course, the treatment for that is totally different. And you can see this is desiccated cornea. So it's just looking thinned out. So, and this is the inflammatory response to that. There was no infection for this patient. So we stabilized the patient for both the eyes and ultimately stepped up the lubricants, added autologous serum, and subsequently the patient is on scleral lens as well. Another patient who had secondary Sjogren's, so that also presents with dry eye, and this patient presented with a perforation in one eye being good enough and the other eye having a perforation with the peripheral vascularization as well. So this was confused with Moorthy with perforation and referred to us. But again, when you see the entire cornea takes up staining, even the conjunctiva, so this is a case of again dry eye, in this case secondary Sjogren's with perforation. So for this patient, we did a tissue adhesive bandage contact lens, though that's not the best in cases of dry eye, but we did that to stabilize the eye for that time being. And this patient is still on active follow-up. So Pterygium is one of those differential diagnoses which is not at all PUK. Sometimes it has some inflammation, but certainly it has this advancing area of lipid deposition. When you see the patient next time, it may advance both from the side as well as a little bit centrally. So it's always been a puzzling entity to me that is it a PUK, is it an inflammation or not? So it's the house currently thinks that it's not an inflammatory condition. So nothing really, no amount of steroids or immunomodulators will arrest this disease. So there's no point giving all that. So this is the classical Pterygium with the lipid at the edge of the blood vessel, just the blood vessel just spitting out all the lipid at the advancing edge. So I already emphasized the point that differentiate the infectious causes. Don't do the mistake that sometimes we do, that if it's an infectious cause, starting steroids will be quite disastrous. And this was a necrotizing keratitis where a patient was thought to have PUK and was only on steroids. In a way, steroids were necessary, so not too much harm done. But on the other hand, this was a patient who was initially thought to be PUK, but turned out to be cantilever. And this patient was also on steroids. So I think we ultimately had, this did not have ultimately a good prognosis. This particular patient just went on worsening. So this I had discussed in an earlier slide. And just to highlight from the previous slide is that both these cases probably require referral and specialized management. So you don't have to manage them on your own. So what about management? So depending on etiology, if it's classic PUK and if it's a Moorthy's ulcer, you can do conjunctival resection, glue application, intensive topical steroids. But more than that, I think that we should start the patient off on at least a short course of oral steroids and at least immunomodulators. In most of my patients I have with Moorthy's, they would be on immunomodulators, and not just the more complicated ones, but all the young patients, all the bilateral disease, all the one-eyed patients, they would be quite aggressively on immunomodulators prior to surgery, such as whether if you want to do cataract surgery or any other surgery, for example, corneal transplant, then you have to step up the immunomodulation aggressively. So to summarize my entire talk, we discussed about PUK and PUK-like conditions. So we need to recognize these two entities very well. And often the PUK-like conditions are something that we can very easily treat at our centers. But the graver etiologies, definitely either you can refer them or manage them combined. So once again, thank you very much for giving me this chance. I'm sorry if I overshot the time, which I'm sure I did, but I enjoyed giving this talk. Thank you.
Yeah, thank you, Somsheila, for the excellent talk, scientific and illustrative as usual. Can you unshare your screen, please? Yeah, is it?
Yeah.
Yeah, okay. Yeah. And do you have the permission to share the screen?
You do, Anil.
Yeah. Yeah, I think there is some issue with the screen sharing. So I think we'll go ahead with the panel discussion. My fellow panelists are Dr. Leta Mohan, who's the head of the department in Perpheral Medical College, that is in Kannur. And she's a senior surgeon and who has been managing all the cases. And she has her wide experience in cornea, treating corneal disorders also. The next panelist, what we have is Dr. Vijayalakshmi from Comtrust Hospital, Calicut. And she is again a senior phaco and refractive surgeon. And I often interact with her in managing and co-managing refractive surgical as well as cornea cases. Now I call upon, now I invite Dr. Mithun also. Mithun is a rheumatologist, only non-ophthalmologist in our panel. He's been the right hand for me regarding management of such complicated cases like PUK. And according to my principal, who's also a rheumatologist, the head of the institution, he says that he's one of the best rheumatologists, even though he's quite young. He had his DM from Jipmer Pondicherry and has been into publications and into academics. So I welcome everyone. So we'll begin the panel discussion with, I think I'll put the first question to Dr. Leta. I think marginal keratitis is a very common disease that we see quite often. And how do we distinguish it from other corneal infections, other peripheral corneal infections?
Am I audible? Am I
Yes.
audible? Madam has already told how to differentiate. I think few points she already told. Marginal keratitis is mainly by the staphylococcal antigen, and it is seen in the periphery, that is in the superior and inferior corneal margin, where the lid infections are seen. So mostly associated with the blepharoconjunctivitis. So, and there is a clear space also between the limbus and the marginal keratitis. That's how we usually distinguish.
Okay, okay. Those are very, very important points. I think having trained in immunology, I think Somsheila maybe can tell about what's actually going on in the cornea, whether it's infection or inflammation or what exactly it is.
So it's certainly not it's not a, infection is the source of it, the bacteria is the source of it, but it's not an invasion by the bacteria itself, but it's an inflammatory reaction to the bacterial toxins, the endotoxins. So it's an inflammation. And sometimes even no treatment, it's a very low grade inflammation. So even without treatment, you can sometimes the condition will resolve. It's self-limiting in that way.
Okay. So I think a lot of people, I think it makes sense to put fluorescent stain and see also. Dr. Vijayalakshmi, what do you see when you stain these lesions and see under the microscope?
Yeah, in marginal keratitis, the lesions, when they're very small, they don't usually take up stain. Yeah. But once they're larger ones, they can usually see some stain in the central part. And if it is an infectious condition, again, the stain will be there. That's how we differentiate it. And as Somsheila madam said, marginal keratitis resolves spontaneously also, and you can give weaker steroids initially. But if there is staining and suspecting secondary infection or infiltration, we'll have to give antibiotics and then start off with mild steroids.
Okay. So I think it's very important that in marginal keratitis, as you see, it will be an anterior stromal infiltrate. It will be crescentic in location. Sorry that I can't share the screen and show some illustrative pictures. There may be multiple in location. The presence of lucid interval is one pointer. And in the initial stages, it may be without any epithelial defect, but as it increases in size, quite often the epithelium breaks down, and then it will take up the fluorescent stain. And it is likely to spread in a crescentic fashion. That is something important. And quite often, marginal keratitis, we see that such anterior stromal scars are there in the same eye, in another location or in the fellow eye. And if you have coexistent blepharitis, that is again another indicator. And if you see these scars with mild superficial vascular recession, it is an indicator that this particular patient had staphylococcal marginal keratitis. What about this? I think we have quite a few contact lens induced infiltrates which you see in the periphery. So if you have contact lens steroid, I mean, what is the treatment that we give for such patients? Whenever you see a marginal keratitis, do you give steroids? Do you give surface steroids like loteprednol or fluorometholone, or do you give dexamethasone? Can you elaborate, please?
Question is to me?
Yeah.
Okay, fine. Yeah, in contact lens, it can be either contact which induced sterile infiltrates or it can be infective. So you must rule out whether it is sterile infiltrate or is infective pattern. Small, as madam had already shown, small lesions usually to be sterile infiltrates. In those cases, we can give them tear substitutes, how to use contact lens for some time, and weak steroids can be added. And I usually give them some amount of doxycycline also in these patients. If it is associated with secondary infection, we'll have to give it an antibiotic, broad spectrum antibiotic is usually given. And of course, you must take care of their lens and their lens cases also.
Okay.
Anil, sir, can I interrupt once?
Yeah, please.
Sir, we were supposed to have a case also, a small, short case.
No, that we'll have after 15 minutes.
Okay,
I think you allowed me only at 11:15. So we have to have the discussion for some time and then we'll go.
Okay, sir. I thought you forgot.
Yeah. I think for the contact lens related infiltrate, Dr. Somsheila, you have anything to add? Because the bacterial counts are generally larger, no? And I don't know, we'll be more careful about starting steroids. Your comments on that?
So I think that it's again a little bit based on the amount of inflammation that the sterile infiltrates have caused. And if it's very low inflammatory, just simply discontinuing the contact lens usage, maybe then sometimes I even discourage the same contact lens and relooking at their care regimen of the contact lens, or changing the type from, like going into a frequently disposable contact lens kind of a situation. So we see this as the soft contact lenses. That would be more wholesome. And for the particular case, if the patient has fairly severe inflammatory symptoms, then of course I would add oral topical steroids. I agree that I usually add oral doxycycline. I think it really helps decrease the staphylococcal load. And usually they get better with this therapy. Even without steroids, it just resolves.
Okay, thank you. Yeah. I think I will go to the cases now because I'm trying to share the screen multiple times. I'll try to sort it out again. So Dr. Lisa, are you there?
Yes, sir.
Yeah. Can you share your screen and
yes,
go through the presentation?
Yes, sir.
Dr. Anil, while she's sharing the screen, can I ask it out? In furrow degenerations, which is usually a benign condition, is there anything to be taken care of when you're performing cataract surgery? Somsheila madam also.
Can you just repeat the question?
Ma'am, in furrow degenerations.
Furrow degeneration, yeah. So yeah, I didn't put a picture of furrow degeneration, but that is presumably just a degeneration, not a
So
inflammatory.
is there any problem is there any particular site when you're doing cataract surgery or anything like that? Should we usually assume the temporals apart?
So obviously I would avoid that particular site which is showing, if I can, if it's located somewhere where I can avoid, so I would avoid that area. And if required, just avoid that area for incision because of the tectonicity, but otherwise nothing different.
Okay, thank you.
Okay, so we have two cases here. Are you able to see my screen?
Yeah, very much.
So first case, we have a 28-year-old male manual laborer hailing from the city of Guwahati, currently working here. He presented to us with the complaints of irritation and foreign body sensation in the right eye of 1 month duration. There was history of photophobia, no history of redness or decrease in vision, eye pain. And on his past ocular history was like in December 2019, he had redness, irritation and watering in the left eye of 2 weeks duration. At that time, he was diagnosed with the left eye inferior peripheral ulcerative keratitis, and he was started on topical steroids, predacetate, and systemic steroids and tab doxycycline. And over a period of time, that is from Jan 2020 to June 2020, his symptoms progressively reduced, and left eye PUK got resolved. On examination, his general examination as well as systemic examination was quite within the normal limits. On examination of the ocular examination, the vision was 6/6 in both eyes and intraocular pressure was normal. Right eye was showing sectoral congestion, temporal corneal thinning with overhanging hedges, and Dellen was seen in the upper part. Left eye was showing inferior healed PUK, and he was investigated thoroughly, and his inflammatory parameters were quite within the normal limits. He was ANCA negative, anti-MPO, anti-PR3 was negative, and he was evaluated by the rheumatologist. And he was started on systemic steroids, omnicotil, and immunosuppressants, methotrexate, and lubricants. On the 5th week of presentation, his right eye lesion was progressing, and there was thinned out cornea, and he was started on topical steroids. At the 6th week of presentation, he had right eye more than 80% of the corneal thinning was noted. So we advised him to undergo triamcinolone acetate and BCL application, but he was not willing for the same. So when he presented to us on 19th August 2021, there was right eye corneal perforation with iris plug, which was following a minor trauma. So we did right eye multilayer amniotic membrane graft, and due to COVID times, we didn't have the availability of the corneas as much as we used to have before. So his post-op vision was in the right eye, it was 636 improving to 6.6. Now the second case, he's a 33-year-old male, security by profession, hailing from Thrissur. He presented to us with the complaints of redness, pain, blurring of vision in the left eye, which subsides with the topical steroids. His vision in the left eye was 660, which was not improving. So this is a diagrammatic representation of how his anterior segment was. So there was peripheral ulcerative keratitis, which was involving almost the entire cornea except the supratemporal area in the 3 to 3 clock hours with corneal edema and superficial vascularization. So a cut section through this area showing the slit, which is the stromal scarring with superficial vessels can be seen superiorly, and inferiorly overhanging hedges and superficial vascularization. So he had the history of polyarthritis involving small joints of hands, elbows, knees, ankles, and early morning stiffness was there. He was started on HCQ by outside of the rheumatologist. He had history of leg ulceration, which was subsided in 2 weeks. So there was definite history of inflammatory arthritis that was pointing towards an autoimmune etiology with elevated CRP and ESR levels. So we came to a diagnosis of refractory PUK, which was with poor response to cyclophosphamide and high-dose steroids. And as you can see in the right eye, it was showing more than 35% of corneal thinning as per the ASOCT and more than 85% in the left eye. So he was given rituximab injection, which was followed by lamellar keratoplasty with amniotic membrane graft. That was done on 18th of July, and his vision was improving. His vision immediate post-op vision was counting fingers close to face. So how we did it is during the procedure, there was 4 corneal segments were placed and multiple sutures were put. And the whole thing was covered by the amniotic membrane graft, and the intervening stroma was also covered by the amniotic membrane graft. And that yellowish graft that you can see is the amniotic membrane graft. So why we had to take it as 4 segments was because it was of the asymmetry of the corneal thinning. And this was a post-operatively later on over a period of time, like when he last presented to us on 19th November, his vision was 612 in the left eye. Thanks.
Okay, Dr. Mithun, are you there? I mean, Dr. Mithun?
Yes, sir, I'm there.
Yeah. So I think primarily it was Mithun who managed this. I did the patch-up job, a surgical job, but the systemic disease management is something very important, and it is better to immunosuppress the patient and get the things under control and then before touching the cornea. So I just want Mithun to highlight the issues that you had, because it was seen by a rheumatologist in that place. Also, it was managed by a nephrologist there. And then the patient came to you and us, obviously. So can you make some comments regarding this particular, especially the second case?
Yes, this is about the second case. First case actually didn't have any systemic symptoms, so there was no evidence of any systemic autoimmune disorder. Most of the inflammatory disorders may not have, inflammatory PUK may not have a underlying systemic disease. We may not find any evidence. Whereas in the second case, there was systemic symptoms in the form of leg ulceration and the polyarthritis. And also she was managed with other DMRs, disease-modifying anti-rheumatological agents for the joint pain. That means patient has a systemic symptom, a systemic autoimmune disorder, which has led to the PUK, or this may be the underlying etiology for the PUK. And we extensively evaluated for those these patients, but all the auto antibody workup was negative. That can happen because one thing is that although the literature says the rheumatoid arthritis is the most common autoimmune disease associated with PUK, nowadays we don't see much RA-related PUK because of the advanced treatment available for rheumatoid arthritis. Most of the time, we see the patient presenting with PUK, or within usually in rheumatoid arthritis, PUK happens in long-standing refractory deforming diseases, not as a presenting symptom most of the time. But whereas in vasculitis and other connective tissue disorders like SLE, they may present with the initial presentation. In the second case, also the arthritis and leg ulceration were not of a very long duration symptom, almost of only 6 months to 12 months duration. Therefore, we suspected vasculitis as the cause because there was a leg ulceration also. As you know, one of the manifestations of vasculitis is cutaneous ulcers. But we didn't have any biopsy to prove that because that was not done previously. And ANGAs can be negative. Even in Wegener's granulomatosis, approximately 10% of Wegener's can be ANGA negative. What we have to do is we have to exclude an infective cause, and which actually we take help of the ophthalmologist and look for evidence of a systemic disorder. In this case, it was arthritis and leg ulceration, which improved with actually steroids and hydroxychloroquine. And this patient has received cyclophosphamide also. And knowing the etiology actually helps in the treatment also, because if you suspect vasculitis, rituximab may be a better agent if patient is not responding to cyclophosphamide, because rituximab nowadays is almost the first-line treatment for ANGA vasculitis. Whereas in rheumatoid arthritis, we can have other options like TNF inhibitors, methotrexate. There are a lot of other options, and even rituximab is also effective. And another thing I want to reinforce is that steroids alone is not enough in most of these cases, because there's a chance of relapse. And sometimes we need to act aggressively. The first case, actually, we started with I think methotrexate, and then, but we have to change to cyclophosphamide because patient developed a corneal perforation later. Therefore, my advice is that you should always, in these cases, you have to take help of a specialist who is managing the immunosuppressive, using the immunosuppressive drugs. And most of these patients with an inflammatory background for PUK, they need a steroid-sparing agent because steroids alone will not do the job. This is my take on these two cases. And one more thing is that in one of the Somsheila madam's case, the rheumatoid factor was positive. In rheumatoid factor actually is a very non-specific test, although it can help us to think that this patient is having an autoantibody, therefore the etiology can be autoimmune. But rheumatoid factor can be positive in up to 40% of Wegener's granulomatosis. Rheumatoid factor is not specific for rheumatoid arthritis, and it can be also present in some infective diseases like tuberculosis. That also you should remember.
Yeah, thank you, Mithun, for the valuable input. I think it's a very pertinent point. See, and also the rheumatologist, what you're talking about does matter the most. You know, the thing is, when I was in the hospital where I was working before, the rheumatologist, they used to be very conservative. You know, only for the eye disease, they will never start the immunosuppressive agents. And it's very difficult to convince them. And as you're aware, a lot of rheumatologists are there who are medicine people, have done a 3-month fellowship. They would have never seen such cases. So people who are really dealing with such complex cases only should deal with these. Otherwise, they'll never be convinced that this is a systemic disease. And you can't do anything about that. The patient will come back saying that the other doctor told that nothing is there. So then you are stuck.
That is absolutely true, but we need to have a good ophthalmologist to say that this is not infective. Then only the rheumatologist will become confident. Otherwise, we are not an expert in diagnosing that PUK, whether it is infective or inflammatory, if there are no systemic symptoms. Only limited to, I think the ophthalmologist has the final say, saying that this is unlikely to be infective. You just look for the non-infective causes or inflammatory causes. I think in that thing, the ophthalmologist has the final say. In those cases, we isolated to eye only.
Anil, can I just
please
butt in with a couple of points?
Sure,
so that was two very well presented cases. I think, I don't know, Anil, you said you managed the second case surgically and medically managed by Dr. Mithun. So I think it's exactly what I'm saying. It's a collaborative effort to manage these cases. In the second case, what were those rectangular segments? That was the AMG or corneal tissue?
Okay, that was corneal tissue.
Okay.
So those were like peripheral corneal tissue after we have taken the central 8 mm button.
Okay.
Then I had kept some amniotic membrane also, like the Aravind people they do. They tell that the amount of inflammation would be less. So I put amniotic membrane at the graft dose junction also. Then I put an overlay amniotic membrane graft on top of that.
Right. So as you said that, I mean, you're very modest, but surgically also it's not easy to do that. It's very challenging. But to keep that going, to keep that surgery going and not having the same disease, that's where the medical management and the immunosuppressants or immunomodulators come into play. And I think Dr. Mithun has summarized it very well, including the point about RA factor being just a sort of a starting point for us to look at whether it's positive or negative. It can be positive, but not in disease, not in the associated disease, not a false positivity. But it's useful to convince the patient and the rheumatologist that, look, we have PUK and the patient has RA factor positive. And for all you know, many of the ocular manifestations which affect the cornea or the sclera, which are collagen after all. So they're an extension of systemic collagen, which you can have in many other systemic connective tissue diseases. And this is the way in which it affects in the ocular compartment. So what we're looking at is an isolated organ, which is the eye, which has a connective tissue disorder. So it's ocular isolated alone. That's what I strongly believe. And so we may not have serology positive. We may not have RA factor really positive, and we may not have the ANCA positivity for these patients, but still they may have the disease similar to the systemic disease. And or it may precede it by several years. But it precedes it, but we're starting the patient on immunomodulators. So we may be allaying the systemic disease in some way. So exactly the points that you mentioned. In fact, many rheumatologists get aghast when they see the amount of steroids we used, and we just sort of left, right, center use 1 milligram per kg, which I believe they use for really life-threatening disorders. And here we're using for eye-threatening or vision-threatening disorders. So I noticed that in the first case was 40 milligrams was started, and we would have very simply started at least 1.5 milligrams, which is a very toxic drug. So these days, the idea is to shift more from oral steroids and to go on very quickly so oral steroids is more of a bridge therapy to stabilize the condition very aggressively. And either we use pulse therapy more often and switch very early and very aggressively to steroid sparing agents, because you're looking at least 1-2 years of therapy for these patients to control the ocular disease. And maybe more. We don't tell the patient that it may require more than that. They'll get depressed and they'll not follow up with us. So sometimes we just say you need long-term therapy, and we just hold their hand with that. So, but these are the more specific and more smaller compartment PUKs. I think the larger group of PUKs that Dr. Vijayalakshmi, Dr. Lata Mohan had chipped in with the simpler cases, so-called, those are the ones that the general ophthalmologists are very much likely to see.
Yeah, I think Anil had to leave. Dr. Somsheila, wonderful presentations. Just one feedback. I have a 7-year-old son who is not fluent in reading. So when we see the movies, he doesn't go to the subtitles. He listens. When we see, normally when we see there is subtitles, even if it is Malayalam, you keep watching So probably it might be a good idea not to have subtitles. So your
Sure.
presentation.
So
Okay. Okay.
to
You
be-
get confused where to look.
Yeah, no, to be very honest, I think that the subtitles is something I've just tried maybe for the second time. I thought actually it's a little amusing, so I thought let me try it and see what it does to my voice. But yeah, I'll knock it off for the next presentation.
Yeah. And Anil, see, wonderful. Anil and Mithun, wonderful tip. So we now know how to see. We know when to refer to a rheumatologist. We now know which rheumatologist to refer or talk to a rheumatologist to say that even if there is no real systemic illness, he might require immunosuppression, steroids, or disease modifying agent. Anil, you're back.
Yeah, I'm back. I mean, I just quit the Zoom and rejoined so that I could open the presentation that I had. I'll show a few slides. I think this is another case I just want to discuss. This is a teen girl who keeps on getting this grayish-white infiltrates, and some of them are encroaching the visual axis, and they have a florid vascularization. You give steroids, it reduces, and then it comes back again. So what do you do in such kids, Dr. Somsheila?
We need to,
yeah.
So it's in very brief, it's going to be difficult. There seem to be a couple of entities that could be causing it. Viral would always be top of my mind for this kind of disease.
So this girl had a blepharitis, and initially it came as multiple marginal keratitis. You see this anterior stromal grayish-white infiltrates associated with superficial vascularization. Over a period of time, it has come up like this, so I just wanted to show this.
So that was,
I think, for this, and I think as Dr. Somsheila was mentioning, some of these cases might be demodex also. You can take the eyelash and see it under the microscope. You can see these agents which can cause this recurrent peripheral anterior stromal disease. So how do you manage such patients, Dr. Somsheila? I think people say multiple therapies, and what do you do in your practice?
So we still use tea tree oil, but I think it works pretty well. It really resolves the disease in our practice. You can also use oral, I forget the dose, but you can use the oral antibiotic as well. I've not used it in my practice, but most of the time now tea tree oil is more easily available. So we source it in our pharmacy and we can use that, and the lid scrubs. They work very well.
Okay.
So in fact, I was just on the verge of mentioning demodex, and you showed us the mite itself.
So I think the child became now 14 or 15 years. The disease came down. I think incidentally we used tea tree oil also. I don't know whether it's because of the tea tree oil, it started improving. She was on tacrolimus for a long period of time when we tapered steroids and all. So I think, do we have time, Srini, or?
No, Anil. I think we'll move on to the next session.
Yeah, fine. Thank you.
A wonderful session, Anil.
Yeah. Thank you, everyone. Thank you, Somsheila, and everyone for this great, really illuminating session. Thank you.
Thank you, Dr. Somsheila, madam, for that wonderful talk. Thank you, Dr. Anil, sir, for chairing this session very well. We got a lot of clinical points to take home. Thank you, Dr. Lata, ma'am, Dr. Vijayalakshmi, ma'am, and Dr. Mithun, sir. So, keeping up, we are very much on time schedule. We'll next move on to the most interesting session, that is common corneal procedures for comprehensive ophthalmologists. I request Dr. Sujit Naina, sir, who is heading the corneal services at Trinity Eye Hospital, Calicut, to chair this session. Sir was a great help and support for this entire CME. His areas of special interest are lamellar corneal surgeries, keratoconus, ocular surface disorders, and infectious keratitis, laser and LASIK lens-based refractive surgery. Over to you, sir.
Thank you. I welcome you all to the session 4. Once again, thanking OSK for giving me this opportunity. Are my slides visible?
Yes. Yes, Sujit.
Yeah, so without wasting much time, let us go to the session 4, which is one of the most interesting session of this entire module. And the key speaker for this session is Dr. JK Reddy. Bigger the name, less the introduction needed. So my job is much reduced. I don't think anyone here will not be knowing Dr. JK Reddy. And his surgical experience speaks volumes about him. And what we are going to tap is his innovative surgical mind. And he finds something new and his own way of doing something new in every procedure he does. And that's what we are trying to tap today. And we will be having him speaking about very common surgical, common corneal problems that every one of us, not only the corneal people, will be dealing in their own clinics. So what we would like to know from him today is like how he's going to help us in managing these things in our own clinics. My co-panelist will be Dr. Jyoti, madam, my own teacher from Kozhikode Medical College. Dr. Umesh, who is a senior phaco and refractive surgeon, OSK member himself. Now he's in Dubai and he'll be joining from there. And Dr. Prashop Mohan, scientific committee member, who is heading the Cornea Eye Bank at Chaitanya Eye Hospital in Trivandrum, and he's a senior consultant cornea and refractive surgery. So let us go to the talk. I invite Dr. JK sir to share his slides. So are we moving in any particular order?
Yes, the order, as you said, I just send you WhatsApp, same order. We will have a small presentation, then a few minute discussion, totally around 6. So each one should finish it in 5 minutes so that we have some time left behind. It should not be, it's a very simple thing. Thanks, Sujit and Srini and Kannur Ophthalmic Society and Kerala Ophthalmic Society for inviting me. This, I feel a lot of people, or at least many of them, might have seen these videos. But what is interesting is the way Sujit is going to moderate and make it a little bit spicy, which is very important for any scientific forum. So coming to the dry eye, so there are two types. One is temporary or iatrogenic induced by postoperatively by putting a lot of antibiotics, steroids, on the permanent one or a balanced one. So how do you handle? The patient will be fine before surgery. After cataract surgery or pterygium surgery, it becomes manifest. A balanced eye becomes unbalanced. So these are the cases where the cornea becomes toxic. After the application, patient will be fine before surgery. But after surgery and putting some antibiotic and steroids, cornea becomes toxic and epithelial toxicity. You can see recognized epithelium all over the cornea, especially in the center part. So what we do is this is because it's induced by unbalancing the environment. We do a temporary punctal occlusion. There are temporary punctal occlusions are available, but what we do is we just use a catgut. Cut a catgut for 3 millimeters, 20 or 30 catgut. It's a freely available. It's very cheap. You can just cut them and put them in 3 millimeter pieces in alcohol and take them and put it in the upper punctum and lower canalculus. Actually, it's not in the punctum. You have to push them into the canalculus. If you put them in the punctum, they will rub onto the cornea. The end will rub onto the cornea like this. So you have to push them into the canalculus. So it will swell and it will block it and it will get dissolved. Previously, we were using chromic catgut. Now we found chromic is a little bit taking long time to dissolve. So we are using simple catgut. It works for 2 to 3 weeks. And by the time patient may recover and the problem may be solved and your steroids are gone. And in case of dry eye, where it's really problematic, we use a permanent punctal cartridge. It works very well. It is much superior to punctal occlusion by Plux. Plux doesn't give even 30% effect of punctal occlusion. So this is what even the SN groups are now, they are shown where there is a punctal Plux are kept and that doesn't work, then they did cartridge works. So how do you do this is we connect to bipolar cartridge. One pole we connect to the speculum and one pole we connect to the needle. So you put the needle inside the canalculus and you put in the low power and press it for a few seconds until you see a white cut. Gives a very nice canalculus and punctum closure instead of putting a hot rod or a hot cartridge. Then comes the watery eyes. If you have watery eyes, it's very simple to somehow the punctal stenosis 3-snip procedure is forgotten technique. It's a 100 years old technique. Why people are not doing, I can't understand. When we ask many places, they are not doing. It's such a simple technique. You don't need to give anesthesia. You can do under topical. Just dilate the punctum and you cut off the do a canal class and open it up nicely. It gives very good relief to patients. So please look at the canal class, like punctum. When a patient, elderly patient comes with watering complaint, please look at the canal class. Don't keep on putting them on lubricant. Then next to you, Sujit, any other discussion about this?
Yes, sir. Actually, in the procedure you have shown, sir, that's regarding the catgut. That's a very useful technique. Like anybody can use it, even in your clinic, you can do it. So, does Vicryl give any help in such thing instead of catgut?
No, Vicryl is very soft. It's a polyfilament, so it's not stiff. It won't go inside the canalicula. So you can use catgut, or you can use. There used to be PDA, one material, but now it's not coming. There's a monofilament, long lasting material, but now somehow it disappeared in the market. So the plain catgut is the best one, I feel.
Okay. And regarding the punctum cautery, sir, like do you give any sort of anesthesia? Is it just topical?
Yes,
or
yes.
just
Xylocaine. For cautery, you have to give. You have to give local xylocaine. For
local xylocaine,
you don't need. For punctum cautery, you definitely need.
You will put it around that only that local area.
Yes, canal plus and punctum.
Okay. My panelists, Jyoti Madam, Dr. Umesh, Prashobh, any quick comments on it? Anything new or innovative which you people are doing there?
I just want to ask whether punctal cautery is done in the upper punctum or the lower punctum.
Yeah, that depends upon the severity of the disease. Generally, if the Schimmer's value somewhere between 5 and 10 and a recurrent problem, then we do the first upper punctum and leave the lower punctum. If the value is around 2 to 3, then we do a lower punctum, leave the upper punctum. Then still, if the symptoms are not relieved, then we cauterize both the other one, step by step.
Okay, so in your practice, like, are you using plugs at all these days, or have you abandoned it?
I use sometimes, so it produces a lot of discharge, granuloma in at least 50% of the patients. You have to put on some antibiotic drops along with that. So these are again problem toxicity. And there you see sometimes granuloma, the effect is also not very great with the permanent, so-called permanent punctum plugs. But more and more people now are sharing that even punctum plug doesn't work, you cauterize it works. So they are showing nice videos. Dr. Bhaskar is having very nice videos where rheumatoid arthritis patients, where I put a punctum plug, it didn't work, then cauterize within 24 hours, dramatic improvement. So when there's
actually I don't remember the exact details of the paper. There's a Japanese paper which shows that they take a fibrous tissue from around the medial canthus and put it into. Once you cauterize that area, you deepithelize the canalicular part. You put in a little bit of fibrous tissue into that, and so just put in a suture at the punctum, so that it works almost like a permanent punctum occlusion.
Sujit, Vanathi has a doubt.
Yes,
in the chat box.
Yeah, what is the depth up to which the entry of the cautery probe is done?
3 millimeters.
3 millimeters.
3 millimeter, I go.
Why is catgut dipped in alcohol? Dr. Seema is asking.
So that's a normal. The alcohol is normally preserved in alcohol. They don't keep it outside. I don't know. When you open the catgut, you can see it. There's alcohol comes out of it. It's a biological material, you know. Maybe that's by tradition. It's preserved in alcohol.
Okay. And as said, 3-snip is a very useful technique, which is often a forgotten technique, which most of us can do in our own clinic. I just wonder, like, why these patients often become more symptomatic after cataract surgery. They may be having these problems even before cataract surgery, but somehow this watering just does it have to do anything with the topical drops which we are using or something?
We cannot be sure, but definitely the topical drops, steroids and antibiotics will aggravate the problem. Even NSAIDs also will aggravate the ocular surface problem. When you don't see anything, also they have a lot of epiphora. Some people will have that. Definitely, these preservatives may be producing punctal stenosis or canal plus problems or reflex photophobia or ocular surface. is a big. They do have problems after cataract surgery. That is sure.
Any role with the speculum, type of speculum that you use, sir?
I don't think ptosis has a role for the speculum or the blepharochalasis. If you put a tight speculum, you may get a lower lid swellings, permanent fat prolapse if you indiscriminately put a lot of tightening. But for punctum, I don't think it can produce unless it is really you.
Prashok,
can I ask
any
a
quick
question?
comments? Yeah.
I wanted to ask, sir, whether if there are any contraindications to doing the punctal cautery when you will not do punctal cautery.
Punctal
cautery. Is there any
cautery.
dry condition that we should avoid or something?
There is a lot of controversy. A lot of people they say is in the toxins are drained off. If you cauterize it, they are going to stay inside the eye. But that I don't believe in that. That's a completely hypothetical, just a situation created to highlight, to draw attention and make some PhD or some papers published. When there is no water at all, no the eye is suffering from. I don't think any toxins or nothing. You just put the drops, it will drain off. So that's what I remember. I don't know. I'm not reading nowadays books. So maybe new things. I don't know.
Thank you.
Okay, so we can go to the next. I think we have more interesting things to come. Yeah.
As a painful blind eye, this is one of the, sort of a gullus, but the complicated cataract surgery. It's not uncommon. They have a anti-segment completely deranged. There's no point in doing keratoplasty. So but there is very symptomatic patients. It's really painful. So this is the Bowman's cautery is a very nice procedure in this. Some they say even stromal puncture is good enough, but usually my boss taught me Bowman's cautery, so I am doing the same technique. But we have to do it under anesthesia. We cannot do it under topical drops. We can give subtenon or we can give subconjunctival and do it also. First, we have to debride the completely the epithelium and remove it. Then we have to cauterize the Bowman's membrane. The Bowman's membrane, now here we are using this one. You see the needle, same method which we used for punctum cautery. One pole of our bipolar cautery is attached to the speculum. The other lead is attached to a needle. So you put on that and you apply the low power for a few seconds until you get a nice scar. But you have to cover very well. You have to cover entire cornea, especially in the periphery. You have to cover very well. The gap, like PRP case, you have to cover very well. They get very good relief. They have pain for 1 or 1 week. Then after that, they will be fine. They get a very good relief. The other technique for this is conjunctival hooding. We are doing it, but it takes a lot of time. We have to remove all tenons. Somewhere I missed the video. I was such and such, I couldn't get it. So I'm not able to show. So next to Sujit, there are many techniques coming to Sujit. Some they are telling you can make a pocket and inject silicone oil into that pocket. So it gives it prevents the drainage of fluid. And I saw nice, interesting things where they are inserting a lamellar pocket contact lens into the corneal. They making a lamellar pocket and putting a contact lens in the pocket so that the fluid transcription to the epithelium and bullae form.
These things actually, sir, will translate into
closing areas from your side.
Yeah, now all these lamellar procedures and all will be more useful for probably a Pakka cornea setup. I think for a comprehensive ophthalmologist, they would more appreciate doing such things like doing a Bowman's membrane cautery. I think, sir, is it the same procedure which we once learned as Celler's procedure? I think, if I name correct.
I don't know.
Cauterizing the basement membrane. Yeah. So, sir, is it like you recommend it only for the corneal indication for a blind eye, or a painful eye, or like?
We do that even in a case of bullous keratopathy with neovascular glaucoma. It's quite common. Neovascular glaucoma is not unusual. It's the diabetics, CRVO, and diabetic retinopathy, neovascular blind eyes, neovascular glaucoma. So they do have bullous keratopathy, but it has to be managed. IOP also a big problem, but the pain is mostly many times is due to the bullae. Rather than to the intraocular pressure of 40-50. Sometimes it goes above 50, they get head pain inflammation. So we are doing the Bowman's cautery for that. But we do give these neovascular glaucomas I do give a decadron, intracameral decadron, and tobromycin, 0.1 ml, 0.1 ml. That atrophies ciliary body, and the IOP also comes down to around 30 millimeters from 50-60.
Okay, I think Dr. Anil has got a question. Sir, can you ask?
Yeah. So that I think I read somewhere that they make a lamellar pocket and put a bandage contact lens, and it.
Yeah, that's what I was mentioning. Yeah. Yes.
So experience on that, sir?
Yes, Sujit.
Yeah. So another important thing would be using a retrobulbar alcohol injection. As you told for a 3-snip, it's a forgotten procedure actually.
I don't know. I gave a lot, to be frank. My post-graduation days, even after joining Sankara, for blindfold blinders, we used to give for retrobulbar alcohol. It doesn't last long, 4 to 6 months. After that, they do get the pain back, and they produce doses, and we have to mix, and post-operatively also quite arterial inflammation will be there with the alcohol.
Any role for retrobulbar transferon acetate for these painful blind eyes?
For neovascular glaucoma, PST is useful, not for with inflammation. When there is inflammatory component, PST is useful for neovascular.
Sir, I have a doubt regarding the Bowman's cautery. Can I ask that?
Yes.
Sure. Yes.
Yeah, you said you have to connect one lead to the, even for punctual cautery, one lead to the speculum and one to the needle.
Yes.
Do you actually disinsert the wires?
Yes, we can separate it. We make a new wiring. That new wires, you buy 2 Teflon wires, they cost you 100 rupees, and you connect them one to this one.
Okay, so you have to do some modification to that.
Not modification, just like electricity. You connect it, that's all.
Okay.
So for this Bowman's membrane cautery, actually you can go with the normal cautery also, no, sir?
The problem is you put a forceps, it won't cauterize. It's so wide, you need a nice punctures and nice looking. You try with the forceps. It just shrinks, you think it's happened, but actually nothing happened. That is called dermal shrinkage, which will relax back and it doesn't produce any effect. It will get healed. So it looks very dramatic, but nothing will happen there. So you need you want to destroy the Bowman's membrane. You can do only with a small needle with punctures and cartridges.
Vanathi madam, any quick comment?
Punctures can also be done.
Yeah, that's what this is.
Yeah,
you don't need to cartridge. They say just stromal punctures.
But yeah, you probably can do it on a slit lamp also. But in a patient with a painful bullous keratopathy, might not cooperate with you well enough to do it as an in-office procedure.
Anyone of you doing cross-linking for this bullous keratopathies?
We tried, Sujit. Somehow not happy with the results. The pain, it's not still we are getting bulle. Even one bulle, maybe from 10 bulle, it will come to 2 bulle, and you can say 80% success rate. But patient agony is the same.
Yes.
Yeah.
Even with one bulle, that is the problem. Technically proving the successful results and statistically is totally different from clinical practice. What is the benefit to the patient?
I might be foolish in asking, but can you use YAG laser for the Bowman's?
You do, Srini, it will take half a day to do all the YAG laser prints. By the time you'll be finishing 30 cases surgery catter.
Yeah.
Dr. JK,
Jyoti madam.
Would tattooing help?
Yeah. What are your present indications for conjunctival flapping?
Conjunctival flap hooding, recurrent, we do for, see here, we are destroying the cornea, okay? I cannot do deseg, demake anything in the future if I want to do. So it's a simple bullet, I cannot do. So if for temporary congenital hooding is not like that, we can come back. Another thing is congenital hooding, especially the viral keratitis with recurrent viral keratitis with bullous keratopathy, painful eye with recurrent episodes, it works very well. Still, they will get viral keratitis, but they get under the conjunctiva, so they don't get that pain and all. They come with a mild inflamed eye, and it works very well with the blind eye. And
So I think one of the easiest, and I mean not the easiest though, but one of the best procedures is a conjunctival hooding or a Gunderson flap for most of these painful blind eyes. They become quiet, and the patient will be, I mean, a lot symptomatic after that if it has been done in a proper way.
It takes a lot of time. That's the problem.
But it's worth, sir. But the patient visiting you every time with the painful eye, and we have nothing to offer, probably it's worth it.
Dr. Sujit?
Yes, yes, sir.
Yeah. Dr. JK, any experience with amniotic membrane in these cases?
Yeah, we tried, sir. It didn't work, but I saw 1 or 2 cases done by my colleagues, Srinivas Kerao and Revati. It worked very well. I saw the post-operative up to 2 to 3 months also, patient 1 year, 2 years after. Yes. They say you have to debride epithelium. They are making a groove all around the periphery. Into that, they are tucking the amniotic membrane and suturing it and doing. Then it's remaining without bulle. I saw it's working in their hands. But when I tried, every time the amniotic membrane is getting dissolved. I don't know where I'm going wrong.
Okay.
A very similar case, like a painful patient coming to you again and again, recurrent corneal erosion. Probably that's what sir is going to speak next. Is it, sir?
Yeah, recurrent corneal erosion. Basically, it's when they have injury, we don't know what happens in the microcellular level. It's like a painting job. You have a paint, you put a primer, there is a wall. What is the job of the primer? If there is no primer, paint will peel up. It will bind both the things. Same thing here. You got epithelium. The wall is the stroma or Bowman's membrane. In between, there will be a laminar layer, which will get peeled off in the trauma, so that the epithelium won't get stuck to the Bowman's membrane. So that is the problem. This is the case where sometimes they come in interval. If you see carefully, you can always find out where is the erosion is happening, where the attachments are not there. It looks normal, but you put a little bit force in and wait and see it, you can see the place. And previously, we used to not to treat them if the epithelium is intact, but we are treating because when you see in slit lamp, when we start in the operating microscope, you don't need to do anything. Just take a cotton swab or a sponge and wipe off, it comes out. Entire epithelium comes. That is not situation. When you're doing PRK, you have to really scrape. That shows the epithelium is just lying there. It's not attached. It's just lying there over the Bowman's membrane. So even in cases where we diagnose RCE and there is no epithelial defect, we are doing now treatment. We are treating them. So this is a case where pupil area, nothing to worry. All you have to do, micropunctures and make the surface a little bit rough for attachments of the epithelium. It works very well. The advantage here with the needle when compared with the laser is, PTK is, you can go to the periphery. Whereas in PTK, you cannot go 8 mm, 9 mm like that to the periphery. You can go maximum 7.5, 8 mm. Beyond that, you cannot go with a excimer laser. Whereas here, you can go to the periphery. And even pupil area, you have to treat it, but you should not go very deep. You should go very gentle, small punctures. And the diamond burr is another very good instrument we found. And this is another case I will show you. Just that's what you see is just wipe off, everything will come out. So wherever there is loose, you don't need to scrape. Just take gently, but it's come out. So you take a diamond burr. There are 2 or 3 types of heads, the smooth, rough. You take a smoothest one and you apply, but you have to really apply. You just cannot touch and come out and get scared. You have to apply really the surface area because it's a very smooth Bowman's membrane. It doesn't make a surface rough very easily. The advantage with the diamond burr is you are not puncturing, so you can do very confidently. And the advantage with the PTK does induce amount of refractive problems, errors. Here it doesn't induce, it's cornea will be. So now nowadays we are not doing puncture, we are doing all cases with the diamond burr. We are doing anything.
Yes, sir. So Sujit, I think
you don't want to treat, or you want to treat? Number one, my question to you.
Yes. That is where I think where we should start, because the audience will be more interested in at what stage you should go for a intervention rather than just do a medical management and keep them waiting. So we should have a step ladder pattern for this particular entity, I guess. So, sir, at what stage should we stop?
My rule is three episodes. If they come with a definite history of 3 episodes over a period of 2 to 3 years, even that's okay. If once it comes 3 times, it's not going to settle down. It is going to come, it's going to become more. 1 episode is okay, 2nd episode, maybe it's a mistake, patient might have thought, got scared. If they say give a definite history of 3 episodes and typically taking 1 week for them to become normal 5 times, they give, I will go ahead.
So then what is your role in role of bandage contact lens in these cases? So do you at any stage use bandage contact lens?
No. That's only temporary only, you know, temporary in that particular phase to get rid of the pain. That's all.
Yes, sir. But so you say that there is absolutely no role for spontaneous resolution of this, even by chance.
No, that's what I believe. I may be wrong.
Vanathi, madam, any quick comment? You may not be seeing too much of these in your institutional practice, probably.
We do see them, but as Dr. JK Reddy says, when he considers 3, I wanted to ask him what is the interval between the 3 episodes he's looking at.
Even 2 years, 3 years, 4 years, it doesn't matter. The problem is I have many patients, you know. One fellow, a doctor, he's a doctor. He says early morning he posted 10 cases, he can't open the eye. What should I do? Even once in a year it happens to me. It doesn't matter, but what I will do it. So we did. Another fellow is a film guy. He put all the shot, and next day morning he will have. He said cancel the shots, and he said everybody became panic. You know, they thought he's becoming psychic.
I still do conventional management only, and I don't go in for intervention. And I do feel they do respond well. But again, I guess depends upon the severity of the morbidity you're dealing with.
Ma'am, having said that, what is your conventional management? What all things you give, and it's just any lubricant or anything particular you feel that is giving better results?
Whatever lubricant the patient is comfortable with, I do give them on. I do give them a short course of surface steroids here, low potency surface steroids there, and then taper them on, keep them on to alternate days, and change them on to an immunosuppressant like cyclosporin low dose. In the initial phase, when they're symptomatic, I do keep them on for a BCL for a short period of time. But then our patients are willing to wait for a period of over a period till the conventional treatment is going to help them out. But as Dr. JK Reddy says, if you have patients who are looking for dot-on improvement and to be symptom-free in a very morbid condition, that's when perhaps an intervention is probably justified.
Considering the pathology, what role does steroids have in this? Because
there is some amount of subclinical inflammation when your epithelium is breaking down recurrently. So that gets controlled, and you're already having a basement membrane complex there, which is dysfunctional. So you're waiting for your epithelium to grow over and cover and the surface becoming comfortable. A lot of them do have a dry eye, kind of a localized dry eye kind of a thing. So that's how your surface lubrication helps in these patients. We commonly see it in a lot of...
sorry to interrupt you. See, there are so many, I attended so many meetings, and here and there I'm seeing. There's a lot of people now, I don't know, when 20, 30 years back, when I visited Kerala, I saw a junior doctor just doing stromal puncture in slit lamp, just wipe off and doing. Now, everybody is scared. They are using for more medical management. Number of doctors doing that is coming down. It's such a safe and simple technique.
I agree, sir. It is a safe procedure, and again, it indicates
how much money
depends on your indication for what you're doing.
Visits for medical management every 6 months with a doctor, and how much care they cannot touch the eye, they cannot rub the eye, it will come out. Is it worth? I doubt. Is it worth when you got such a simple treatment available?
I believe because of it, film star director has become your fan and friend, right? So it's worth giving them the treatment.
Somsheila, madam, any quick comment on this? On your style of practice for RC, if at all you are seeing any of these?
Yes, the question was about bullous keratopathy, and I completely
recurrent erosions.
Recurrent
corneal erosions.
RCE.
The question for recurrent corneal erosions is first medical management and then the contact lens for a short while. But the next level would probably be just to do localized PTK that really works very well. But of course, if it's basal membrane dystrophy, we know that it will recur after some time, after some years. But typically, I do use a contact lens in between, because if it's a traumatic kind of a recurrent erosion, then it will settle down at some point.
Yeah, to JK sir and other panelists, like my next question is like whether this indication, the trauma, or whether it is due to some other cause, does it make any difference in your step ladder, like how we approach it? Especially sometimes we don't find any trauma or any particular incidents of trauma or any other case, and you just have starting recurrent erosions one fine morning. Many of them say that after pregnancy, after delivery, the immediate nursing period they start, because when they start, I mean, they get up early in the morning to feed the child, suddenly it starts. I've heard many of them saying that. I don't know any particular relation. Is there hormonal cause? Is there something? Any comment on that?
I don't think this is, no, it's not that. I don't. It's maybe just a coincidence there, the stress induced. Otherwise, it's the same. It's the condition is the same. Just like a cataract, traumatic cataract or non-traumatic cataract, congenital cataract, the treatment is the same. Here also, it's the effect, what you are seeing here. The treatment is the same. It's a very simple and a very effective treatment. I think we have to popularize more. Then we have to fight with medical management.
One problem with anterior stromal puncture being done by a comprehensive ophthalmologist who is not very expert in it is probably he may not go deep into it. Doing especially on a slit lamp. You do it on a slit lamp or on under?
No, I don't do. I don't, because they don't pay me. So I do in my if I do in slit lamp, I cannot charge them 15,000-20,000.
Okay. So I think when they do it, they may not again go to the adequate depth, or probably they will. And Prashab was asking regarding the scarring. So when you're doing it in the pupillary area, they are scared of doing it for the cause of scarring in the central area. So that is one probable cause. I've seen the dexpanthenol has got very good effect on the healing. So anyone else have noted it or not? So I give a lot for these patients. Dexpanthenol ointments.
Antigel, is it?
Yes, Pantogel, yeah.
Yeah, Pantogel works well, but I think there is a problem in its availability now.
In between it was there, but now it was now many alternate companies have also come up with that product, and personally I feel that I don't know any particular study has been done on it, but personally I feel that it is doing a good thing. If
can I ask something?
Yeah,
okay.
Sure.
Yeah, has alcohol delamination gone out of favor at all?
Yeah, exactly. That is what I wanted to.
A few cases it doesn't work. I saw Dua talk in Abu Dhabi, so I tried few cases. 3 cases I tried. All 3 cases recurred after 6 months. So I had to again do them a PTK or diamond burr abrasion. So we stopped. That's what Rajesh Sinha also last time when we discussed, he also tried. He also had same. It's not working that well as Professor Dua is claiming.
I think Vinay is
the other
doing
thing
a
is
lot.
hypertonic saline. Does anybody use it for medical management? Because that's my first.
They do a lot in Chennai, especially in Chennai. I don't know. They are fans of hypertonic sodium chloride for everything. They use a lot. They give even once a day, lifelong. They say they don't get in the night time when they apply ointment. But it's a very simple thing which can be cured. Then why you want to treat? That's my argument.
Because that is what my go-to thing. I mean, my patients 80 to 90% get hypertonic saline at night, and most of them are comfortable. Yes, if you stop it, it recurs in many patients. But they say that the epithelial remodeling takes months, sometimes 1.5 years. I have seen few patients of mine who don't get recurrences after a period of say 6 months to 1 year of applying hypertonic saline, and they stop it, it doesn't recur. So that is my personal experience. I thought it was done by everyone. Because
how do you use it? Vanathi, I mean, your opinion on that, because you and
I also do use hypertonic saline once daily, and I shift them, or when I give them surface steroids, I combine it with hypertonic saline as a short course, and then shift it on to lubricants and change on to cyclosporin. But again, I said, if you're looking at epithelial basement dystrophies, if you're looking at surface dystrophies which are causing, then these treatments will not be very helpful for them for a long period of time. That is when interventional modalities will going to be differing.
Before we move on, information from Dr. JK Reddy to all who are listening, how to get the diamond burr.
Diamond burr is very cheap, easily available. Diamond burr is not in, see, all these techniques, what we are discussing today, they are more than 30, 40 years old technique. Somehow ophthalmic practice became defensive practice, where first we think about bad things, then we think about a court case and you standing in the court and our lawyer asking questions, then we decide about all the treatment, how to escape from that, then we will plan. So this is called defensive medicine. That mind we have to come out. If we have to go to the court, we will go to the court. If we have to go to the jail, we will go to the jail. Like that, we have to treat the patient. Then only we will come the
no, sir. Like
so the diamond burr is there for a long time. We can. This is available from Epsilon. This is just 8,000 rupees.
That's it. So you can get it from Epsilon.
Yeah, 8,000 rupees, 8 to 9,000 rupees, maximum 10. Maybe the dollar rate has gone.
I wanted to ask you something regarding the anterior stomach puncture and the diamond burr. How is your recurrence rate after that?
Almost zero. Never. I never had. No. Especially with the diamond burr, you don't get it. Anterior stomach puncture, yes. You sometimes you miss an area. Especially for as Anil was telling, Sujit was telling, they are worried. You not go deep and you don't touch. You just do a small area. You wipe off and do it. In diamond burr, we just cover entire cornea. You don't get it. It's very safe also. No. Then coming to the diamond burr, what are the other uses? Once you use it, you cannot just wait for a RCE case, So there are many cases like this is another beautiful indication, shield ulcer with a plaque. This is a wonderful image. This is the best way to do these cases. You can just do on the topical anesthesia, put it, comes nice bed. No need to do dirty scraping and peeling off tissues, nothing. You get a very nice smooth surface. And once you get rid of all that plaque, then you can give supratarsal triamcinolone. That will take care of this patient. And it works even for post-PKP. This may not for a comprehensive or general ophthalmologist, for corneal surgeons. So post-PKP cases or doll case, sometimes you have a keloid. You don't know what to do. You cannot scrape them. You cannot remove them. So this case also, it works once you do that, you get a very nice topography, which looks very irregular. It takes a lot of time, but it works very well. You can remove nice that marginal keloid. And even you can use for PRK haze, but I didn't have any cases for a long time. See, now it looks so bad. Now it became clear. After it takes 4 or 5 minutes, you should be patiently do it. Another one is band keratopathy, especially with the calcium deposits. Now, after putting EDTA, you have to wait for years for it to get dissolved. At least half an hour, 15, 20, 30 minutes. You put a EDTA, then you put a diamond burr. It's very nice. So I got bored. I had 2 or 3 cases one day. Then I told staff, give me diamond burr. Then I put it. So it is working very nicely. Within few seconds, everything you can just you put EDTA, but you put a burr, and nicely you can remove this band keratopathy. This is seeing eye of the patient, good eye of the patient. This is not a non-seeing eye. The other eye is still worse. So this fellow is complaining of defective vision for few months because the band keratopathy, myotic pupil, and the band keratopathy. So it works very well. You can get a very smooth thread instead of using crescent and everything to scrape. Very nice it works. Any thoughts, Sujit? How many people are using diamond burr or is having? It's an old instrument.
Yeah, I'm not using it, sir. But I always wanted to buy it. Like even I think it is even available in Amazon. So it's just it's a very. I've always thought like it will be a very useful. So regarding band keratopathy, like other than so you always go for this, and if again if we are talking, we are having this discussion for. I'm audible. Yeah, we are having this discussion for comprehensive ophthalmologists. So other than diamond burr, like what we can think of and what they can do for the band keratopathy. See, we always yeah. So regarding EDTA, it is
a problem.
Yeah, regarding EDTA, when we tell EDTA, it's all about procuring EDTA, mixing EDTA, and using it in the proper way. That is probably what they would like to hear from us.
the only, that's initially I did, my postgrad, I forgot 10, 20, 15 years back, they told them they are continuing. They just buy in a chemical store, the modern scientific company, which they sell for school, all chemicals, they sell it. So you have to fraction it to milligrams in a microbiology lab, the milligrams, they will fraction it. After that, you can do a gas sterilization and keep it. So mix it with the 10 ml of BSS and use it on the table. But MS Ravindra says you don't need to worry, Dr. MS. He says you can directly put the EDTA on the cornea. There is no need to. That's what I remember one day he was, but I always dilute it. And
frankly speaking, I've done it, sir, without any complication directly. But now, nowadays we hear more of discussion about the potassium EDTA also, which is quite easily available from the labs, which may be quite, So what they are saying is, have you used it, sir? JK sir, have you used it?
Yes, no problem.
Sujit, there is an echo from your part. JK sir, his question is, have you used potassium EDTA?
Hey, tell me. Yes, go ahead.
No, Sujit.
Yeah, I'm audible. My sound is okay. Yeah, okay. So there was in the corneal groups, there were discussion about this potassium EDTA. What they say is that the labs, which the containers which we collect the blood in the labs, it is having this potassium EDTA in it. So we need to I just forgot, I think it's like you have to put 1 ml saline into that one container, and 4 such containers, and add this, and this will give you a proper concentration. And I've tried it, it gives a very good result. That's probably useful for a general ophthalmologist. The blood collecting containers in the lab, it is having potassium EDTA. If you put 1 ml in one container, such 4 containers you have to take and mix it together. It works similarly as a sodium EDTA. So I've tried it in 1 or 2 cases, it gives a good result. This is what probably some we can use it in our own clinics, those who have got labs associated with it. Sir, any comments on it, or have you used it? Or
I have not tried. That's a good idea. This is easily procurable. You don't need to go to run a chemist and sterilize. All these problems are solved.
Yes, exactly. You need to just borrow 4 containers from the lab and put 1 ml in each, just mix it together and use it just like what you use for a sodium EDTA. You need not go for this chemist and all those things probably. So any other things, like Vanathi madam, do you use any other methods for band keratopathy or?
No, I think it's calcium EDTA. We have it freshly prepared from our labs, but what you said also works well. And I think it's 4 or 5 tubes of 0.3 ml of solution.
Yeah, exactly.
In each tubes, and they are all transferred into one, and then you can use. Only thing is, when you're using calcium EDTA, diamond burr is a fantastic thing. I think it really hastens your removal. But if you don't have a diamond burr, you might have to do repeated applications. But always remember to scrape off your epithelium, then make your applications, and you might have to wait in between. So if you don't want to wait, and sometimes your wait could be as long as more than 5 minutes or 10 minutes, and then it goes away, especially if they are deeper into the stroma. And you do have these recalcitrant cases where it comes back and it is deeper and your removal is not complete. So that's when your diamond burr really comes into help.
Jyoti madam, a quick comment from you, because it's more easy to procure this EDTA in an institutional practice. Jyoti madam is there?
Yeah, we also used to use this sodium EDTA 3% and scrape it with that. Previously, we used to do that. We used to procure it from the lab only, not this what you said.
Okay, madam. So can we go to the next, sir? Next.
Yeah, this commonest one, Descemet membrane detachment post cataract surgery, specifically. So you see a nice surgery, you done it, or a complicated surgery, you see a keratitis and corneal edema. Previously, we used to have a lot of tricks: switch off the lights, put a beam, and look for Descemet membrane. But Nowadays, you don't need to, you can see, but nowadays it's very easy. You got anti-segment OCT, you see a nice DM detachment. So the life became very easy when compared with the 15 years back when we used to struggle to identify whether it's a detachment or not. Now it is very nicely OCT, you can see it. But how do you manage is the problem? The simple answer is the air injection. The technique is, the question is, will it clear? Yes, if you do early is better. If you do later, it should not become fibrous. Once it becomes fibrous, it will become a taut membrane. Then you have to do additional procedures. This, for example, is a phakic patient. Somebody did a trabeculectomy. So during trabeculectomy, side port, it got detached. So we injected air and it became clear. You can see a phakic eye. So all this works. So the technique is how do you do it? So what we have to do is we have to select an area where it is clear, where the cornea is very clear. Don't go into
so can I interrupt at this moment before we go to the technique? Like a person sitting in the periphery would like if she does a cataract surgery, sees a unexpected edema in the postoperative period. The first question that comes to it is whether it is a Descemet detachment or not. So if an OCT is not available, does that pattern of edema in any way help to tell us that it's because of DM detachment or it's just a postoperative edema?
See, generally what we look at is, we look at a certain portion of the cornea is very clear and certain portion is suddenly you transition to and that island-like marks, then we suspect DM detachment. Then you can have, if you have a large DM detachment, full cornea, you can have a full cornea white next day in an unsuspected case also. But these are the ones I don't have any other specific things in my mind.
Okay, sir. Okay.
Sujit, see, you have a clean cataract surgery, not a very hard cataract, and you get a white cornea next day. Definitely, you should suspect Descemet membrane detachment because you're not expecting this much of striate keratopathy or even a little bit of striate keratopathy. See, if you're done a brown black cataract, then you get it. Then you can be in two minds. Otherwise, not a dense cataract, you get total corneal edema the next day. Then you definitely should suspect Descemet membrane detachment. That should be your first suspicion.
So the problem happens here is whether you go for an injection or not. You're seeing this patient next day or second day. You have to decide whether you have to go for an injection or air bubble injection or not. That's
slowly they resolve. I don't say they never resolve. They resolve, but takes a long time. So so many times they think that by not doing second surgery, many surgeons, when I advise them, they say, no, I cannot take up surgery in second day. Patient will be very angry. How can I convince the patient? But this fellow will be visiting you every third day for another 2 months, even if it gets spontaneous result. So this is visiting second surgery and facing him is much easier than facing him for 2 months every week, every third day or fourth day. So better it will be finished in 1 day. So but you have to take it up early. No, because they don't see good vision. So some will resolve. I don't say all, some will resolve spontaneously.
Very few will resolve, sir, spontaneously.
Okay, so we can go ahead with the technique.
So the technique is you go very close to the limbus or even scleral also you can go and go with the cannula. Don't inject the air. Just take off your thumb from the syringe. Automatically air will be injected by your thumb without your knowledge. So take off the thumb, that's very important. Go to the opposite area where there is a detachment, which you OCT has seen or you see on slit lamp, then inject. So the basic philosophy here is, when you inject the air, it will roll the Descemet membrane against the corneal stroma and it will squeeze out the fluid through the tear, whatever tear. But if you inject the air from the paracentesis from clear cornea, the air bubble will push the Descemet membrane up and you get a fluid trapped between the Descemet membrane and the stroma. Fluid get trapped. You will have a nice air bubble, but there is a fluid separating. So that once the air bubble goes again, they will get a detachment. So to avoid that, you have to go to the opposite, then inject the air bubble slowly. So the air bubble will squeeze off the fluid between the Descemet membrane and the cornea, and it will close. Once it happens, they do very well. And there are sometimes you see a lot of complicated folds. So this is for this case, we did a paracentesis. I mean, not paracentesis, venting incision. Opening take the fluid from that, and they do very well. For example, you see this case with so many folds, here fold, here fold, here fold, and there is a venting we did, we couldn't settle it. And in spite of that, post-operatively, same patient, you can see it's not another patient photograph. It looks so clear within, even air bubble is there, within 3 days, 2 days, the cornea becomes so clear. So this is the same patient. You can see this venting opening here. So then what are the complications? Pupillary block, yes, it is a rule rather than exception. You dilate the pupil, you put cyclogic, nothing, Diamox, nothing works. If you put enough air, you are going to get 100% pupillary block glaucoma. It starts, when it starts 4 to 6 hours from the time of surgery. It starts on the table, but it takes 3 to 4 hours for the IOP to go such a level to produce pain for the patient. So ideally between 2 to 4 hours, you have to see these patients and you have to burr the air out. You can do it in slit lamp. Just take a Sinskey hook and tap the opening, which we made paracentesis. The air will come out. So this is the pupillary block. So when you see in slit lamp, there will be air and it will block. Here you see a small fluid. If you don't see the fluid, you are going for a pupillary block. If you see an antechamber small fluid line like this, you don't need to worry. If you don't see it, then you have to tap and remove the air from the clear cornea. You have to little remove the air. But some cases will be there where you cannot remove the air because they are long standing. After 1 month, 15 days have come, multiple tears, and complicated looking like. So in those cases, what I do is I do a PI, inferior PI, not superior PI doesn't work. You have to do somehow it doesn't work. You have to do inferior PI. This is what we learned after doing DSEC and DMEC. So you do an inferior PI. All can be done in topical anesthesia. You don't need to worry. Patients will be very cooperative. You see after injecting air, you see the Descemet folds, nothing are settling down. It is more than 1 month duration case. So we are making again venting incisions to drain the fluid and make it a little bit, so many folds, it got fibrous. It's a taut Descemet membrane. So this is what I'm telling you, better we do early than waiting to come to this stage where sometimes results are good, sometimes not good. You see here the fold, you can see literally even in 2-dimensional video, you can see a fold standing out and fibrous. So, but they do settle down. Most of the times you should be patient enough to make opening, but they do settle down. And I leave the air. Once I do a PI, I leave the air for, I don't remove the air. Anything, Sujit, from we are exceeding time. We can stop with this.
No, sir. It's too interesting for.
So these last two, the DM detachment, and the next one we have few tips on the pterygium. I think this will be most look for by the general ophthalmologist. So there's no time limit. This is the last session. We have no other work other than having a lunch.
May I ask, JK sir, like you said, an inferior PI will let you not take the patient again for air removal. So if
we don't take the patient.
No. So if you can actually do a YAC PI, if there is visibility there, inferior YAC PI, can you do just inject air and just forget?
So for injecting air, you have to do a paracentesis, sir.
No, YAC. I'm talking about YAC PI.
That's what
YAC
PI.
PI.
Injecting air itself, you have to do a paracentesis. Some
before
paracentesis you can use for surgical PI because YAC PI, sometimes they bleed in the post-operative period and they get close with the fibrin membrane. There will be some amount of inflammation. We can't see such well in a DMD cases. The surgical PI is a good option for me, and it's very clean cut, no inflammation and no bleeding. Even vitrectomy, you get bleeding, that will get closed. Even vitrectomy people.
Can I suggest? I do a inferior YAC PI for recalcitrant DMDs regularly. Not when I'm injecting air alone, but when I'm injecting a gas. It's a complicated DMD, especially if it is inferior. Then I do a
like
large yak PI.
You
when you put
do
the
it.
air, the bleeding stops actually. If you are doing a yak PI.
You are saying that you are doing it through a clear cornea which is available, or if it's like limbus to limbus, still you can doing
so if
it.
some visibility is there, our glaucoma people are able to do it mostly. Or intraoperatively, you have to go in. If you can go in with a vitrectomy probe, 23 gauge vitrectomy probe, it is we can get a clean PI. That is also possible.
I tell you, Sujit,
yes.
The problem is even in institution we are having so many people. When you tell a PI through a paracentesis, everybody is scared. They are not able to do it. That's what. To be frank, we have to be frank. Why we are looking for vitrectomy probe PI? Why we are looking for as a PI can be done? It's very, very tricky. You have to see and learn the technique of doing PI. You cannot just see a probe and do a PI. They can't even catch the iris. They will be picking. They cannot catch the iris. They will be poking the lens everywhere. So the PI doing is not very easy through a paracentesis. We have to really, that's what we need to understand.
So that's why this more easier technique of doing it with a vitrectomy is being sought out.
Yeah, popularized, but now vitrectomy PI, yes, you have to make a paracentesis go on. But vitrectomy PIs, most of them, they do bleed. They have small amount of bleeding. It will get controlled, but they do bleed.
In a situation of Descemet's membrane detachment, how do you actually go with the probe and not hit the Descemet which is hanging down and
no, you first actually flatten it with some air inside, then only go.
Under air, you go and
yes, and obviously there'll be fluid flowing from the another pole when you're doing it.
Yeah, because I mean, when I mostly take off the air in 3 hours time, and I never had to do a yak. That's Dr. Somsheila Moorthy just mentioned. Doing a surgical PI. It's one of the real valuable tips that we got from this session. Yeah.
JK sir, one more. Doing PI. We have to do it. We should not get worried. What will happen? I may not be able to do it. I may fail it. We should not worry. We have to try.
The problem is everyone is used to the tunneling. This thing you're entering so deep inside and doing a PI through that. We're not really doing it frequently, so that's why, as you said, we keep on trying to get the iris. And see, one more about the technique that you are mentioning. You said you enter at a site where Descemet's membrane is attached, then you go to the other side and then inject air. So is there a possibility? So the Descemet is toned there. So when you're injecting air and the Descemet is down there, is there a possibility that the air might go between the Descemet's membrane and the stroma and cause more detachment? Because
that's what we came to a conclusion. This is better. So initially, when some surgeons they shown this and what to do, when we told them inject air, so they made a paracentesis where there is a Descemet detachment and injected air, they detached full Descemet's membrane.
Yeah.
Full Descemet's membrane gone. So that's why here, when you go to the clear cornea and put a new blade and cut nicely, at least you are sure you are under the Descemet's membrane. That is the reason why we are selecting a clear cornea instead of selecting a where there is a detachment.
But having said that, yes, sir, please continue.
Yes, go ahead, Suji.
No, having said that, we want to get these things managed by the primary surgeon himself in the clinic. Actually, the DM detachment, the entire classification and the management is now being modified based on the ASOCT. So ASOCT is almost like a must do investigation in this, so that you will know the type of DM detachment. Actually, the type of DM detachment, Dua himself have come up with a paper of 3 types of detachment: type 1, type 2, and a mixed type. So in type 2 is the taut one, sir, which JK sir was mentioning. The taut one is not going to work in a way like simple air injection or desmetopexy may not work that easily. So what is your opinion on it? Like there is other methods like desmetotomy and all those things being mentioned.
That is a no, that cannot be done. We are talking now, as you said, for general ophthalmology. Forget about it. That's why I didn't show any class. That's why I'm saying you don't get it tense taught Descemet membrane on second day, third day. Why should it become Descemet membrane taught in second day or third day? No. We are leaving it, expecting it not to take the patient second time. We know everything. So after 1 month, 15 days, then they get fibrous. Then you have those problems. So don't go to that level. That's what you have to send to a corneal surgeon. He may be that first time he is reading a paper and doing your case, cutting the Descemet membrane or touching. You may not have done before. So better you finish it first day.
The message is early intervention. Early intervention.
Once he gets a vision, he will be happy.
Yeah.
You
So
don't
the message
allow
is
them
early
to go to that
intervention.
stage. They are dangerous cases.
Sir, sometimes what happens while injecting the air is when you make the paracentesis and you inject the air just keeps coming out, especially if this patient is squeezing or if the pressure is high, positive pressure is high. The air doesn't stay at all. You get a very small air bubble, everything keeps coming out through the paracentesis. You have any way to deal with it?
That's a common problem. That's a common thing. It's not anything special. If you make a very small paracentesis, you cannot drain the aqueous out. What you are doing, you are replacing aqueous with air. So you have to replace the aqueous. So aqueous has to drain out. So you need a paracentesis size quite enough to send aqueous out. And when you are injecting the air, the aqueous has to come out. Though you can't see it, it has to come out. Otherwise, so when you inject the air, the only tip I can give is take a forceps, plain forceps or a toothed forceps. When you're taking that lip where the paracentesis you made, just press it down at the limbus. That holds very nicely. Especially when you're pulling off the cannula out, or if the air is coming out, just press that with the forceps, that lip, then it holds very nicely.
Something which I've been doing recently is I make the paracentesis, drain the aqueous, then I go through another place with a 30 gauge needle and inject the air through that without making paracentesis. That way the air stays much more. I mean, it does not leak like that. Does anybody have the experience of doing that? Recently, I've been trying it. It's working.
You have to make the 30G needle. You are entering with the needle, or you are make a small paracentesis.
No, with the needle directly. Paracentesis I make to drain the aqueous, and then go enter with the needle.
That's a very good technique. Only issue is the eye becomes soft once you do paracentesis. Soft eye sending with 30G needle, it is possible. It is not. I'm not saying it's not possible. It's a bit tricky for a simple.
You might end up causing a detachment because
it's a bit tricky. It's very awkward. Collapsing eye, entering. You need some tricks to do that.
So probably it is better to go through a paracentesis. The take home message probably is that you have to drain the aqueous before injecting air. Can't just go in with a 26G needle and just inject air. That's not going to work, right, sir?
Yeah, okay.
Yes.
Next,
Okay.
Pterygium, we are running out of time because I want to skip. Will we stop it or?
We will finish with the Pterygium, sir.
We'll continue as long as it takes. No problem.
Pterygium, there is any pre-operative we do or you don't need to do. So what general ophthalmologist precautions? There are a lot of precautions. Just don't see a symposium pterygium and think and do every case. So whenever there is a possibility, you put them on cyclosporin drops. If it is a flushy, very aggressive pterygium, put them for a month before you take up. It reduces ocular surface inflammation, and post-operative also it becomes very smooth follow-up. And 40 years and above, you do not worry. You get excellent results. And 30 to 40 years, there are chances of recurrence. You have to do very meticulous management post-operatively and peroperatively. And 20 to 30 years, almost recurrence very, very high. I try not to do those cases. I try to push away if there is no option. If that fellow is after me, only I will touch it. Less than 20 years, I'm scared of touching the case. They can almost always we get recurrence. So this is you just inject a little bit xylocaine with adrenaline into the pterygium head, and just before start surgery, we apply brimonidine eye drops to reduce the vascularity. And when the pterygium head is very much near to the pupil area, we don't try to put any blade there. We try to peel off the head so that you get a nice smooth surface there. If you put a blade or crescent something and try to do that, you get a very irregular. You may get a clear cornea, but you get a very irregular surface, which is refractive wise very bad for the patient. Patient loses vision. So once you remove how do you remove the pterygium body? So we cut some amount of conjunctiva. We are removing. No need to cut, but it looks very bad at the end of after your successful surgery. So whatever looks conjunctiva, keratinized, and hyperplastic, unhealthy, and not very clean, that portion we cut it off, and you pull and cut the pterygium as much as possible. And this is even covering the pupil area. So we are just doing like a rexis, we stripped off. So we got a nice bed on the center. The other portion, you can use the scarred portion, you can use a diamond knife to smoothen it out. And you got a cover area which you cover with a conjunctival graft. So conjunctival graft is taking, ideally is measure and put 10% extra and mark it. So this video is not showing marking, but it's better to mark it. And very thin graft. They should not pick up any tenons along with the conjunctiva, because the tenons is the main pterygium. Subconjunctival tissue is the main pterygium. If you replace the tenons again, there is a possibility of again the tissue will become recurrence, like it comes as recurrence. So you have to take only conjunctiva, very thin transparent conjunctiva without any tenons from the donor side, and you put it in the cornea and dry it. That's very important, because you are putting a glue. If you put a glue on a wet surface, that will get diluted. That is becoming 1:1 dilution, very thin. So it may not stick. Dry the surface before you put the glue, and you put the tissue glue, the thicker one. Then you do fibrinogen, you add it. Then wait for 10 to 30 seconds. Don't immediately turn it. So once you have 10 to 15 seconds, then you turn on that. Then you spread it nicely and remove the excess glue from under surface. You don't need to remove. You just press it nicely and smoothly. So the excess one will come out and remove it. Another thing is, if the conjunctival graft is too much mobile at the end of surgery, you put a glue, you put the graft, still it is not stuck, it is mobile. Most of the times it will be the conjunctiva is reversed. You are trying to stick epithelium surface. Epithelium cannot get glued by it needs a rough surface. If it is moving, don't think the glue is not working. Don't try to lift and put some more glue and put it back. Take off the graft. If the graft is not attached and it is moving at the end of surgery after a minute of one, take off the graft, clean up entire glue, and look carefully for the surface. Most of the times, if you are sticking the epithelium side down of conjunctival graft, it won't stick. If you put a tenon side down, it will 100% will stick. So this one. And when you are applying the mitomycin, another tip is don't apply on the sclera. You apply on the subconjunctival, because that is from the tissue is going to come back, not from the sclera, not from here. It doesn't come from here. It comes from here, the tissue. So apply only here. If you apply here, you are going to get it necrosis of the sclera. So carefully apply only for the subconjunctival, far away from the limbus, the mitomycin. So post-operatively, I tried a lot of combination. First few days, at least for a week, you need dexamethasone drops. After that, I'll shift them to loteprednol. And I do use stimulant. It's supposed to reduce the tenons, granulum, and vascularization on ocular surface for a month to 2 months, lubricant for 3 months. And I put most of them after stopping steroids. After 1 month, I put additional 2 months on cyclosporine. This one. Sujit, any thing to add? It's a very old technique, conjunctival autograft. It is more than 50 years, 60 years, my grandfather's time technique. Anything?
Do you still use glue or because
glue? We have glue always available. So we became.
So do we really need glue? Because I don't use glue at all. And it makes
blood.
More time. I just keep it. It stays. I've not seen any of my grafts go without glue. Sujit.
Yes,
That's
I
what-
always use glue, but as you said, the autologous blood.
Surgeons use glue. You ask Vinay, they use glue. You ask Dr. JK, he uses glue. You ask Anil, he uses glue.
We have done, Srini, we have done without glue some cases. But the advantage with the glue is always available for us. 24 hours it is there in the theater, available for retina, pterygium or congenital tear, skin surgery, for everything they use, they stick onto the glue. So it's already available. You need just one drop so that you can push off the patient very fast confidently. It's a good method. Even for without glue, I saw the results are good. I don't say results are bad. They are very good without glue also. Now they are using tinoxamic acid. Anybody is having experience that the injection tinoxamic acid 1:1 dilution without just they're rubbing the blood and put a drop of it and putting the. I read a lot of people they started using glue because it's very economical. It just costs few rupees.
So what anesthesia do you give, sir? Topical or
subconjunctival we are giving. We are not giving peribulbar unless it is a very complicated case.
Prashop, do you use? Another corneal surgeon. Do you use glue?
I use glue all the time.
Yeah.
I used to do with the autologous blood and all before, but then it gives a lot of subconjunctival hemorrhage and it's not cosmetically acceptable. And what I've seen is that large grafts, it tends to dislocate. And the glue always gives you peace of mind. And if it is autologous, in my hands at least.
Jyoti madam, like how is it being done in medical college setup? Like, do you either?
We use either autologous blood or sutures.
Okay.
Nowadays, tranexamic acid is also coming.
Lack of availability.
Yeah. So, how is your results with autologous blood? It is like, do you have any detachments or loss of graft or anything?
Not much, because we have to wait for some time till it stabilizes before we give the pad advantage. So just otherwise, I think it gives good results. The problem is graft displacement and graft loss, but whatever we have done, we have not seen such.
See, like Dr. Somsheila just mentioned in the chat box, it's available for you. That is why you're using it. Maybe we even for us pure cataract surgeons, like it might. It's not that very difficult to have it, but I've used it also. But it works. Like see, I don't believe in taking blood from there and keeping it. It's just the same blood. From the graft side and the donor side, we just the trick is just that you should it should just be the conjunctiva, no tenons. You keep it there. Then probably the only times when I might use a glue or suture could be in case of recurrent pterygium, because in case of recurrent pterygium, it's not that easy to remove all the tenons from the bed. Probably in those cases, glue and or suture, whichever. It's a non-corneal surgeon's viewpoint.
Yeah, it works very well. It works really. It works well. Only thing is a bit more time you have to spend. We got used to that. That's all. It's very comfortable.
Umesh sir has got some points.
Yeah. Dr. JK, do you use mitomycin in all regular cases or just?
No. As I told you, there's less than 30 years old. I use mitomycin, and recurrent pterygium I use mitomycin. Otherwise, we don't use it.
Okay, fine. Thank you.
So, what is your method for the double head pterygium? How do you go about it?
The double head pterygium, most of the times we split the graft and put it on both sides. We had tough cases where there is enough conjunctiva, but we didn't harvest from the other eye. We supplemented with the AMG. We had a recurrent pterygium where there was a large defect. Then we take some labial mucosa also formed the fornix. So like that, we go on their necessity. But we try to avoid. Personally, I try to avoid taking conjunctiva from the other eye.
Why, sir?
So we don't know. This pterygium most of the times bilateral. If that guy 40 years I'm operating, there are 50, 60 years he gets the pterygium in the other eye, then I know I won't be practicing by the time. It's of course that's a different story, but still it became a habit.
So, but do we really have to screen for glaucoma before taking a conjunctival? Because we take it from superiorly, and later on you might require to do a trap, like no MIGS or whatever trap where you need the conjunctiva there. Do we really have to make sure that the patient doesn't have, or having glaucoma is different. A 35-year-old who might get a glaucoma later, and you're taking all the
very important, Srini. This is glaucoma, familial glaucoma is more troublesome than what in my practice I saw than non-familial glaucoma. They say my father had glaucoma, my mother had glaucoma, or my brothers had glaucoma. These guys, when they get glaucoma, also treatment is very difficult. Somehow they don't respond that well. Especially if they say they became blind, then you have a real terror case with you. So those cases, better not touch the superior conjunctiva.
Okay. And my question, one question to Dr. Somsheila, and if Vanathi, if she's there, do you routinely use timolol post-operatively after pterygium? Because I'm not used it. I might start using it now. Like
no, I must confess that I've never used timolol post pterygium, and probably because where we practice, some of the very bad pterygiums don't come to us. So I think it depends on our practice pattern, what kind of cases we see. So no, the answer is no.
And like continuing with cyclosporin after stopping steroids?
Again, no, I think because same that the pterygium we see are not very aggressive. So for recurrent pterygiums, I do use for multi-recurrent pterygiums only. I may.
Madam, you're muted.
Sometimes the multi-recurrent pterygiums, one of the problems is that the primary surgery may not have included a good enough conjunctival autograft. So by doing that, repeating that part, we get a good outcome the second time round. But otherwise, most of the points Dr. Reddy has covered very well. So I think practice is, he's defining it for us.
Sujit?
I think we can
yeah, we will
the session.
conclude. Before, just give me 1 minute. Just,
yes, sir, sure.
When we talk about all basic techniques, whether these are all 40, 50 years old techniques, what I am telling, what I told, still we are struggling, we are discussing whether we should do it or not do it. So what is the future techniques, whether we can do it? That is the question, whether in a simple setup, like without much back. So the new one, the artificial endothelium, it's the Israel group started. So we were looking into that, whether we can make and do it, some problems. So we started manufacturing with my friends and we started implanting. What we did is we made 2 wings for it and we tried to tuck the wings in the cornea and put an implant. Initially, the first 1 week, you can see the implant and you can see a gaps, the small gaps are there. You can see here a nice gap between the implant and the stroma. So we are improving on the design, but luckily it has come down and now it's got attached. This is 1 month old picture. It's got attached. Now we are improving the design so that it will get attached even the first day. Some design specification. This is the patient. In the other eye, I did a DSEC and a phaco and IOL. She's quite happy. The size became, we're not getting eyes and she's become so painful. So we opted her our option. If it doesn't work, I will do DSEC and a phaco. They said, okay, go ahead. So we implanted the implant. This is a 1 month old picture. She is a case of macular corneal dystrophy with bullous keratopathy, both combined case. The cornea is already hazy, but with the bullous keratopathy, which is, so it became much better and she is able to see something better than the 624. She has improved. And the problem is she bought her brother also for surgery now for same implant, who is suffering from same condition. So it's just 1 month old result. It looks like a very promising technique in the long term. Thank you for
What material is it? Like I didn't get that.
This is just a Contamac IOL material. 25%.
So you are just replacing it with a
just like
material.
DMAC, but the problem is first 3 cases we tried, like the company said, DMAC, all they fell down. So one case only we are able to retain when we tucked it under the Descemet's membrane lip. The lip of the Descemet's membrane is there, so I tucked it, so it retained, and she got a reasonably good. Now we are adding 2 wings on both sides, 2 wings. That angulation we are putting in that, we are making corneal tunnels. Into the tunnels, we are inserting that ring so that it won't fall, it will stay. And the dimensions we are fine tuning to make it come and attach to the cornea.
Sir, is this the same as the endo art thing?
Same thing. That is the trademark. I cannot say endo art. That is the trademark.
Okay.
That is like a contact lens like material, right?
No. IOL material.
Hydrophilic material, if I remember.
Contamac is a UK-based company, of course, now bought over by Chinese. So they make IOL intraocular lens material and contact lens material for a long time. So this is they're from Contamac material.
And you are involved in the design of this?
Yes.
And
this is we are designing here. We are manufacturing.
Yeah.
Okay, so good.
So it is just barrier. So you're removing the Descemet and just putting this as a barrier. That's all you're doing.
Yes.
So that raises a lot of questions about what endothelium is doing.
No, there are so many things are there. Nutrition and all. So we are replacing only 6 mm. The other portion provides nutrition. There are so many things. We have to try and see what happens.
He's Sujit, my teacher.
So I think we can conclude the session. I thank JK sir and all my panelists. And Seema, back to you for official vote of thanks.
Yeah. Thank you, Dr. JK Reddy sir, for that simple and very useful, very practical tips. This last session, we got a lot of taking home message. The simple tips were very superb. Thank you, Dr. Sujit Nayanar sir, Dr. Jyoti madam, Dr. Prashop sir, and Dr. Umesh sir for hosting this session wonderfully. So finally, on behalf of OSK, we sincerely thank SOS for giving this wonderful opportunity to host this CME. And lastly, but not the least, I thank all the audience who have spared their wonderful morning Sunday morning to share with us. And once again, thanks to all the speakers who have shared their knowledge with us. Thank you.
Thank you all. Thank you.
Thank you.
Thank you, Sujit.
Thank you, JK sir.
More time. You should not. We did a mistake today.
What is it, sir?
We took more time than hour.
No.